mean for it, but lots of AI and lots of. You want to pick a question?
Yeah, I would love to.
Yeah. How are you?
Great.
Good.
How are you?
Thanks so much. I'm looking forward to field therapy. That's why I came.
Oh, no, I didn't. I'm not presenting. It's Sonia. It's me.
So I was just,
Yeah,
it's wrong.
Be here.
That's right. It's wrong on the thing.
No. It's because me and
switched.
Sonia switched because of
Ah.
oral boards and my mental health.
Or boards.
Yeah, she has oral boards in
When?
December.
I think I was supposed to present the week
December?
before.
Yeah.
Okay.
So it doesn't. Yeah. So just not to make Sonia.
Okay. Now the date is set or no?
Dates are set.
Okay.
Yeah.
Not just a week. The date.
No. Dates are.
Morning or afternoon?
Morning, get it done.
That's actually great because then you have so many choices for return
person.
visits.
I only had one that could work unless, because one of them was 2 p.m. and I was like, that could be, well, I don't want to be stressed about missing my flight when I'm sitting there.
I had the 8 p.m. and then it didn't leave until 10. And then I got back at 4 a.m.
I think mine's 6 p.m. or in the evening.
It was really upsetting. I put somebody for coverage for you.
I have to check.
There was quite a bit on your topic at his walk.
Really?
Yeah. A lot of Beatles, genetics, stuff.
Yes. I did. So, okay, I'm going to switch it to that was straight up. The color was actually called
I want
Mandarin.
to know what's funny. That's the first thing I went and looked at. Like, I didn't even look at the schedule.
Are we muted or we're live?
No, we're live. We're
Okay.
live in action. That is hilarious.
They're hard to pick from, right?
Yeah. Number 2. Some feel good vibes.
Oh my God. Well, it's almost 8:15, but do we start? Yeah, we should start at 8:15. Good morning, everyone. Good to see the people on Zoom, the people around the table. Happy September 18th. I think it's always like the best time of the year in terms of weather here in Philly. Next 10 days will be great. We had the case review, the SEN updates, field therapy with Sonia. I'm really looking forward not only to Sonia, but also to Dr. Berg from the Moores, doing some follow-up case reviews and then reviewing the outpatient list at the end of the morning. Quite a few announcements. As you know, we're done with the rank list and interviews. October 1st is the match. Whitney, you want to say anything about the RCT here as well, or no?
I do have some things to say. Maybe I can also, I've been sending lots of emails and lots of text, but for the fellows, when you're on inpatient service, while PACES is running, if you could remind the residents at Big Board to consent laboring patients as well as scheduled C-section patients. I'm also adding all of you guys to the Red Cap to help with doing postpartum pain surveys before the patients leave the hospital. Thank you so much, Sonia, for kicking it off and doing a great job getting them done. Some of the residents are helping as well and are on the IRB to do that, but I've basically been sending Sonia staff or secure chat every morning to be like, these are the couple things that I need done, which is wonderful. And I appreciate your all's help. Yeah, I think it's going really well.
I think for the fellows, not to put Winnie on the spot, but that's how a randomized study is successful. And now we should do the same thing. And you have to just pay attention to detail, remind everyone, send messages, unless you keep at it. At some point, sometimes, it becomes a little bit more automatic, but really, unless you keep at it, then you'll see your recruitment slow down. So well done, and I think that's obviously the secret why you're recruiting so well. Rupsha should be congratulated being a member of a permanent study section. The NIH is a really big deal. So congrats for that. I think I've said it before, I saw the movie about Anthony Fauci recently, and I read I'm almost done reading his book, all the NIH, stories, and it's a really big deal, even this day and age, to be embedded in those, federal level, really big organizations. You kind of know where research goes nationally and internationally. So very congrats, Rupsha. I went to ESWAG, and I just wanted to spend a couple minutes telling you, my quick summary. It was a big conference. AI is taking over. Well, actually, this morning, and even locally, you guys know about ambient notes. We discussed it in faculty meeting. So ambient notes are AI supported epic notes, so that you can just walk into a patient and then AI can scribe your notes. That's going to come to you, I think, in the next month or so. The attendings currently already do it. I don't know if others.
It's not going to update the problem list, and so don't get too excited.
And very, yeah, I agree. But it's a way of the future. Rupsha,
I was just gonna say, I think on our end, I think what it would be helpful, or it could be helpful for, is in consults getting to HPI. It'll kind of it'll outline someone's overview on their chronic hypertension history, diabetes history, last pregnancy, whatever. And then we can populate our assessment and plan as we do. Someone else mentioned using although it'll draft an assessment and plan for you, you can just cut and paste that into your problem list. So it still saves you from having to write up things. So I think there's still potential if you're interested.
And they are, the person who talked to us about it this morning said that they're trying to figure out how to integrate problem list documentation with it. And so hopefully in the future, we will be able to use it more seamlessly without the need to cut and paste, like Rupsha said. But it does seem like it might be very helpful for HPI and background.
Yeah. Again, at the meeting, I think, there are now quite a few companies, doing AI for fetal ultrasound imaging, and they had really amazing, displays of what they can do. A lot of first trimester ultrasound, including AI read, basically around the world, at least in Europe and much of Asia, they're doing routine anatomy scans at 12 weeks, 13 weeks. And the AI is helping a lot with those. A lot of people are using AI, even in the US, for example, anatomy scans. And they had a lot of even live examples of, you just, blindly, without much knowing, go around, belly at 20, 25 weeks, whenever you're doing your ultrasound, or 12 weeks. And AI is capturing, the fourth chamber and the outflows and the vessel flows, etc. Alfred Buhama gave the best lecture I've ever heard about venous abnormalities of the venous system, which is always something we always discuss, when we find them hepatic, but anywhere in the body. Genetics was out of this world. Behind the scenes, you'll often learn more by talking to your colleagues about what's going on. But Mary Norton told me that she thinks in a couple of years we'll have exome from peripheral blood available. So you can imagine what that will bring if you can, instead of just saying, you're gonna get you're an amputee, you want to know gender, sex or not. Now you're gonna end up offering exome, and there was a huge discussions about all the mutations of a non-significance, and what that's going to happen. There were actually great lectures about that in general. Like a lot of our specialty, if you think about it, especially on the the fetal side, you find something out. Let's say you find an NTD, and a lot of it historically you refer to how somebody with a spina bifida has done postnatally, right? You know, the incidence of anomalies and stuff. But really, that's very different if you find somebody at birth with something versus if you find something at 12 weeks or 20 weeks with something in terms of genetic associations, prognosis, etc. So it was really interesting to see some of that. There were presentations about fetal therapy, invasive fetal therapy, meaning, you know, they've treated alpha thalassemia in utero, many genetic things in utero. There are now a list of like hundreds of different conditions that can be treated in utero, hundreds. And the different drugs you can give or enzymes, replacements, and autoimmune or immune, you know, side effects or no side effects, lots of good stories, lots of not so good stories. So it was really fascinating. Nicolaitis told us that they're about halfway in recruitment for Aspre for twins, you know, like doing first trimester preeclampsia prediction in singleton and giving 150, 160 of low dose aspirin. We don't really have the same data for twins. So they're randomized about 1,500 of the 3,000 or something like that, you know, that they need. And he said by January 2028, they'll finish that. I don't know what was going on. So there was a lot of interesting, fascinating stuff going on. With that, any other announcements? What were things you wanna?
Just a reminder for AIUM, I know SMFM is, I think next week, I want to say the 26th, but I could be wrong, will be releasing their decision. So remember, AIUM is here in Philly, great opportunity to submit an abstract.
It's really a good conference. And again, you know, when we talk about fellows, you should begin to think about, you know, like even longer term, what are the things like, you know, if you're a more maternal infectious disease, you would infectious disease, you know, if you're more fetal genetics, maybe ESOG is good. You know, talking about AIUM, it's unbelievable if you're interested in, you know, fetal ultrasound in particular. Many MFMs have been, you know, leaders there and go, and it's in Philadelphia, so it's easy to go.
They also often have hands-on courses. I haven't looked at what the program is, but often there's hands-on courses or including things like fetal echo. So it's something to look into.
Yeah. They also, you know, help with coding and billing and guidelines that we follow over there at SMFM. So it's really. So the question of the day will go around. There are always new faces and faces, and you know, introduce yourself first, and then what has been the best day of your life so far? What has been the best day of your life so far? That is a great question. My God,
I'll start.
yes. Can't wait.
Yeah, it was August 23rd, 2023, which is 2 days after my daughter was born. And the first day that I had my son and my daughter, I might cry, and my husband in our house in Virginia, and like seeing the two of them together and like feeling like we were building the family that we wanted and had tried for so long was just like so overwhelming, and obviously still is very overwhelming. I'm just so happy. Like the best day ever. Yeah.
August
23rd, 2023. Oh, and I'm Whitney. Sorry. I'm attending.
I'm Sajid. I'm one of the visiting residents from New York. The best day of my life. Can I mention two of them?
Yeah.
Was when I got married, and then when my first son was born. I was extremely happy. And also, kind of when I was finishing my medical school back in India, I was the best graduate of my medical school, and it was Women's Day, so it was like I really felt good, and my parents were so proud of me. So
Congratulations.
Hello everybody, I'm Pierpaolo, visiting resident from Italy. I cannot choose a best day in my life. I wouldn't be able to, but for sure I can choose the best period of my life, which is the current one.
Oh, man.
New experience, so it is by far the best period of my life.
I'm Justine, I'm one of the third year ICN fellows. I would say the best 2 days of my life. I graduated med school on June 6, 2019, and then I got married 2 days later. And I genuinely can't say which day was better because it became a doctor, which is my lifelong dream, and then got married and had all that love in one place was the most wonderful 48 hours ever.
So mine is really hard to choose, but if I had to pinpoint one, 2 years ago, we did a family trip. My mom lives in the UK, my dad lives in Grenada, so I don't see my parents very often. And I'm my mom's only child, and I have a cousin who is technically kind of adopted because she's like been around with us for like my entire life, and we all visited my mom in England with my husband and my nephew. And we went to Wales, we did a Portugal trip, and it was just really nice to be surrounded by family, kind of stress-free for 2 weeks. And I'm hoping we can do that again soon.
I'm Sonia, I'm one of the second-year fellows. I also think it's really hard to pick a favorite day, but I think so far it would have to be my wedding. It was really incredible to have all of our favorite people in one room. I don't think that will ever happen in our lifetimes again. And we had a lot of family from abroad, from Ireland, India, Iran. There, and
I'm Kavisha, one of the third year fellows. I would probably also have to say my wedding, but I would have to say specifically the haldi or the tomb ceremony specifically, because that was like a little bit smaller, and it was like my family and Anthony's family coming together for the first time, and everyone got along so well, to the point where everyone exchanged numbers, like extended family, and like they're hanging out without us now, which is crazy. So it was just really nice to see people from like two different cultures, backgrounds coming together. It's a really cool way.
We're doing, did you hear what we're doing, Aaron? What has been the best day of your life so far? And I have lots of choices, but the ones that makes me tear up the most, it's probably actually July 19th, 2025, because to see some of you, 4 kids all hanging out, dancing away. Federica's so happy. My brother, my sister, her family, everybody. They were around. In fact, my nephew Vincenzo, my sister's son, for an hour cried and sobbed because I think it was his best day of his life, hanging out with his cousins, and, together, on the beach, beautiful place. And so, yeah, when you have family like that all together, it makes a difference. Anyway, Yen.
Hi, my name is Yen. I'm one of a second year fellow. I think I have to echo with Sonia and Kavisha. I think the best day of my life was my wedding. I think everything comes together so beautifully, and then just seeing, both our family are just so happy for us. It just makes me so happy. Like I've never seen my mom drink and dance, and it is amazing.
And who is next? Sophie, you're next.
Hi, I'm Sophie. I'm one of the third year fellows. Mine used to be my wedding, but then I had the most perfect baby boy on January.
Can you speak up a little bit more, Sophie?
Can you hear me?
Yeah.
Yeah? Okay. Mine used to be my wedding, but then Dr. Bender delivered my most perfect baby boy the end of this year, and now that's the best day of my life. It's tied with the day that my mom had a mastectomy for breast cancer, and we found out that her lymph nodes were negative. Both those days make me very emotional.
Oh, that's nice.
Yeah.
Thanks for sharing that. Amanda, are you on? Amanda, can you hear us? Or maybe we'll move to our Melissa, Stephanie on.
Hi, good morning. I'm here with Rachel. Stephanie is not here. She is out sick.
Oh, sorry.
Poor baby. But obviously my favorite day was also my wedding, just echoing off of everybody else. Yeah, it's just really special having the different people from different parts of your life come together and meet and celebrate. So yeah, it was really special. Okay, Rachel, do you know?
Let's see. I'd probably say me and my family went on like a big European vacation a couple years ago. So that was like the best 2 weeks of my life. But really, any day where like my whole extended family gets to come together, like holidays, it just makes me really happy. So yeah.
Thanks for sharing that as well. Rupsha, are you super busy or can you share?
I can share quickly. I think I would have to agree. I think it's very hard for me to pick a specific day, but I would agree that this is the favorite period of my life. The kids are like at an age that it's just, they're very interactive. Like when they're little, they're super cute, but they don't know if I exist or not. And now, it's just really fun being together as a family, and it's fun being in a job I love. So I agree. This is the best period of my life.
Thanks for that. That's great. Thanks for sharing. Moti, are you on? Can you
Yeah,
share?
what was the question? Sorry, I was just the patient.
What has been the best day of your life so far?
Oh man. I would say
You don't have to say so depressed. You can say more. I'm just kidding.
graduating medical school, maybe.
Makes sense.
Yeah, or just anything related to the steps of med school, residency, fellowship, starting here kind of thing. I guess that's 4 days, but all important days.
And Alexa, are you on by any chance? Or anybody I missed? Oh, that's right. Then go back to yours.
I mean, I love my husband. He's my favorite decision, but our wedding day is not my favorite. I don't actually love to be the center of attention. I think probably you'll be surprised by that, but I don't like that. I like the simple days where, you wake up and you have like a perfect cup of coffee and like the sun is shining, like one of those
Thanks for
days.
the perfect guy.
Yeah, one of those days I like better than a
Perfect kids.
wedding day.
Understand it. Very good. That's great. Excellent question. That's one of my favorite questions ever.
Actually, I came up here to tell you guys a horrible story and then I have to go see patients.
Sure.
But I wanted to come and tell you in person. I'm gonna really try hard to get through it. No, I can't hold your hand. I'm gonna. Okay. Yeah. On September 4th, I met Tiana Bell, who was 29 years old. She had a telehealth intake with me. She checked in late and didn't have service, so I told her to come in person the next day. She came with her partner. I scanned her. She was 13 weeks. She gave me her history of chronic hypertension, congestive heart failure, 21-week pregnancy termination the year before for 10 days in a coma that she said was from pneumonia at Crozier. I told her I would get her records. I told her that she should get some labs done. I ordered an echo and an EKG, and I set her up for cardio OB 12 days later. The nurses called her cardiologist the next week, and they told her that the medical examiner had called them that day as well, and that she had died 4 days after I met her.
Wow. So sorry.
Her labs came in posthumously. Her BNP was 700. I've had a really hard time processing this and thinking of what I could have done differently. We don't know why she died or how she died. I assume she had heart failure, but because she didn't go to a hospital and was found at home, I have no details of how she died.
Let's try to find out.
I mean, Ryan is aware, Savannah is aware, everybody's aware, because I didn't know if we should escalate to risk. None of this is, relevant. You didn't meet her. She wasn't really fully our patient yet, but I thought it was an important story to share. And I wanted to come and do it in person, even though obviously I'm having a really good time. I'm meeting with Dr. Braverman. I keep seeing her face. She was so beautiful.
And she had one kid.
She had a teenager like a long time ago. She was a
21-week loss.
And she had a 21-week termination that Tino Tran did last year at Crozier.
Mm-hmm.
And obviously we didn't have records of that. We still don't, because Crozier's closed and it's a little tricky to get records right now from them. But yeah, the nurses called the cardiologist that she had been seeing. She was on Precardia 60. When I saw her, her blood pressure was 150/90. I popped in to talk to Dr. Bender and we increased it to 90. And I think I did all the appropriate things.
You did.
But I can't stop thinking about like what I could have done differently.
None of us, I don't think, would have done anything differently. We probably would have missed a few things that you did instead. You know, we save a lot of lives. We do all the time. You guys all do. And I think we're the hardest the best, but the hardest profession in the world, because this stuff happened and they will happen to you, you know. So thanks for sharing, Carrie, and we carry them with us forever. You know, unfortunately, you know, you live in the acute phase, but you won't forget this case ever. And it's really important you talk with Andrea, you share it with us, we talk about it. I can't think of something like, you know, bring it to the hospital for whatever reason. You know?
First thing I did was call
Dr.
Bender and say, like, what should I have done? And there's like,
you set up the echo, you set up the cardio OB, you know, everything. You didn't have the records, even if you had the records, and even if your ejection fraction was whatever, you know, 30%, there wouldn't have been, you know, an absolute.
It was 4 days later.
Yeah, and you know that I also asked about, like, you know, she could have had a car accident. You know, it sounds like maybe it was her heart that failed, and maybe it was related to her pregnancy, but she was also 13 weeks. You know, she was pretty early. Usually,
she had no
cardiomyopathy kills you later in pregnancy.
Shortness of breath. She felt great. She wanted to be pregnant.
Yeah.
You know,
How old?
29 years old.
Wow. And she had a 13-year-old, so she had or whatever you say.
Yeah, so like a 12
teenager.
As a teenager, she had a kid. Like,
so she had a kid. And she was with somebody, you say? The
partner was with her.
Okay. Right. And you know, the partner would have, that's another thing that may make you feel a little bit better. Like, you know, sometimes partners, like, you know, we have a lot of patients that deny what's going on with them. You know this better than anybody. And don't bring up, you know, maybe the chest pain, or like, you know, if they don't say, but the partner would have brought it up. You know what I mean? If something was going on, I think.
I mean, she wasn't super health literate. Like, she couldn't explain why she was in a coma.
Yeah.
You know, she said, I woke up and I wasn't pregnant anymore. And Dr. Tran had told me that he had to do it, you know. And I was like, wow. I haven't reached out to Tino because I don't think that that's appropriate. I don't know.
Yeah.
Anyway, I'm sorry to bring the mood down. I just
No. Thanks for sharing.
wanted to share her story.
Yeah.
And I hope we get more details about how she died.
Yeah. Please share more if you hear anything else. I mean,
I appreciate you saying that.
Yeah.
There was more that I could have done.
Yeah. And you know, we're very much sometimes the way, again, this is personal, everybody deals with it differently. You know, I try to brain the thing, meaning, you know, because if the emotions are so overwhelming, that I try to say, like, you know, let's see what happened, what was the story. I'm not sure it would be inappropriate to contact Tino or to look at those, like, you know, but everybody's different. Sometimes it's better to put it aside and move on, and you may hear more. Sometimes.
I just think like Tino's probably better off not hearing the story, you know.
Yeah, maybe.
I don't want to know if you know, I do, I don't. You know what I mean? It's a heavy weight actually. And I feel like I'm fine, and then I start to talk about it again, and I get upset again. I'm just that's the cost of doing this job. Is what happens sometimes.
Yeah, that's why I often say, you know, if we got paid $1 million a day, it wouldn't be enough, you know, for all the responsibilities.
And honestly, when you asked best day of my life, like one of the days that came to mind was meeting you and getting this job. It's
No.
Truly
Anyways, yeah.
my life, and it means a lot to me, and I'm grateful to practice here.
Yeah.
And this is the burden that comes with doing such a precious job.
Yeah.
And I think it's a good reminder of how precious life is. But we're gonna have to find a way to pivot and move on and talk about other patients. And I have to actually go see patients now downstairs. But thank you for listening.
Thanks for sharing. That's important too.
You probably will hear about it because I did escalate it up just in case.
Yeah, that's good. Good. That's cool. Thanks for sharing. Yeah, I'll see you downstairs later on. Yeah, the responsibilities we have are astronomical, life and death. And, you're MFM, interested in MFM. It's, the stuff happens, there are hundreds of maternal deaths in the US every year. And, hopefully we'll continue to decrease them, but they're sicker patients as well. They're older, sicker, and sometimes, you do the best you can and it's not enough. So very, very sad story. Well, let's move on. And if you want to go back to this, we certainly can. Are you good sharing inpatients?
Just gonna see my screen. We're just moving a couple things around here. All right, so the first patient here is Miss Dana. She is a 25-year-old G2.
You have an echo.
What was that, Dr. Roman?
I can hear an echo.
Yeah, are you on your phone as well?
Yeah, mute one of them so we don't have, we're good now. Go ahead.
All right, so this is a 25-year-old P0112. She is status was a primary C-section at 33 weeks, secondary to acute fatty liver of pregnancy. So she is now post-op day 1, and she's overall stable. So this patient presented with the classic signs of acute fatty liver of pregnancy. She says over the last 1.5 to 2 weeks, she's been having some nausea and vomiting, not persistent, occurring once every couple of days. And then the day of admission, or the day that she presented to Methodist, she had severe nausea and vomiting at work and also started to report myalgias in her body. That all prompted her to present to Methodist. At that time, she was having nausea, vomiting, polydipsia, polyuria. Her T-billy was elevated. She was hypoglycemic. Her glucose was 62. Her LFTs were elevated. Her creatinine was elevated, and her urate was also elevated. After their evaluation there, they were concerned of acute fatty liver of pregnancy, so they called and she was transferred overnight 2 nights ago to Jefferson. On presentation, these findings were confirmed, and given the concern for this diagnosis, she did undergo a primary C-section. She had her—
How many weeks was she?
33 weeks. Yeah. Her pregnancy was complicated by dye-dye-tuned pregnancy. This was her first pregnancy, and both babies were boys. So those are 3 of the risk factors for acute fatty liver of pregnancy. Her postpartum course has overall been stable. She's remained normotensive. In terms of her labs, her LFTs have continuously trended down, most recently 191/37. Her creatinine trended down, trended up, trended back down, so it's ultimately stable at this time. Her T-billy has been trending down. Her ammonia, amylase, and lipase have remained normal, so we have a low suspicion for pancreatitis, which can be a complication of this condition as well. The only thing I'm a little concerned about is her coags. Her PTT, INR, and PT have been stable, but her fibrinogen has been persistently decreasing. Yesterday, her fibrinogen decreased to 176, and even though she was not having any bleeding, I was concerned given her recent major surgery, postpartum status, so we did transfuse her 1 unit of cryo. Her fibrinogen then went up to 184, and again this morning it's back down to 175. Otherwise, she's clinically stable. She has no symptoms. She appears very well. We had hepatology come see her. They don't have any concerns at this time for liver failure. We are ruling out other causes such as viral hepatitis. We have a low suspicion for drug-induced hepatitis. But I'm a little bit concerned about her fibrinogen, and I was curious what the team thought about the fibrinogens. Would you continue to transfuse even though she's not bleeding? Human hepatology said that they typically don't transfuse for their non-pregnant patients if it's greater than 150 with no bleeding.
Yeah, I mean, I think with most of the like liver processes, whether it's HELP or acute fatty liver pregnancy, it does take time, right, for the process to be reversed, even though you've delivered her and sort of, right, started the chain reaction of her getting better. I probably would not continue to trend her fibrinogen in the absence of bleeding, like, or two, transfuse unless something changed clinically. And that might be an unpopular opinion, but I don't, like, it's gonna get better.
Yeah.
It's just gonna take a minute. And if she's clinically doing okay, I don't know what the value of that is.
I think my concern was in the event she did start to bleed postpartum, which is not uncommon, and her fibrinogen is low, getting past that and catching up would be hard. Can I give you a full step again?
So, I'm on the Bender side of things. You guys know how much I love fibrinogen and how aggressive I am. I transfuse very quickly for even lowish fibrinogen and stuff. But that's, when, somebody is bleeding and it's at RDS and stuff. Here, I think we know what's going on. It does take time and she's not bleeding. And she's 48 hours, you say?
No, she's a little bit more than 24. Yeah.
I mean, you're really transfusing a lab without something else. And usually, you have a lot of fibrinogen because you've got major postpartum hemorrhage, you have something else, going on. You can certainly keep on training it, she knows, but who's your attending then?
Dr. Roman.
Amanda, what do you think?
Yeah, I was quite the same. Yesterday, should we transfuse or not? We debated. I was not jumping into the transfusion. Definitely, Sonia has a reasonable concerns, and in the idea of bleeding, I think she's at high risk of bleeding, and if she starts bleeding, she's going to bleed out. So that's why we transfused yesterday. The fibrinogen is not exactly getting that better, but it's stable. It's not dropping more.
Right.
So I'm okay with continue watching and continue doing coax every 6 hours, and if it drops, then again, I'll transfuse more. But at this moment, it's stable in 170s, not the ideal one, but she's not bleeding more than usual for a postpartum one.
What does hepatology think of how often you should trend them? Because I feel like fibrinogen is also, it would be a marker for me of her liver function. And so if we were still not out of the point where she could go into acute liver failure, would you
We're also doing acute checks every 4 hours to be sure she's not in liver failure. And so far, her glucose has been normal and she's tolerating PO. The LFTs are improving slowly, so it will take time for the liver to get better, and their kidney function is not getting better at all, but she's having a very good urinary output.
Yeah.
Clinically look good. So I think we can keep watching very closely, still doing all these acute checks and lab work every 6-8 hours.
Yeah, her glucose has not become hypoglycemic again since that first time.
Was she ever altered?
No.
And her ammonia was always normal.
She's very well appearing. Typically you expect this ill appearing picture jaundiced. She looks great.
Good.
So that's her. Other than asthma, she has no other complications this pregnancy.
She get a dose of beta before her section.
She got a dose of beta, but we didn't.
As you shouldn't.
And then just a little bit of teaching. One thing that we use is a Swansea criteria. There's a couple of different criteria here, and if you have 6 or more, you have high suspicion for acute fatty liver. So I'll just quickly go through those. vomiting, abdominal pain, polydipsia, polyuria, encephalopathy, elevated total bili, hypoglycemia, which is defined as less than 72, an elevated urate, leukocytosis, elevated liver enzymes, elevated ammonia, elevated creatinine, and a coagulopathy, as well as imaging findings. She had 7, so she had criteria, but despite that, I think regardless of the criteria, she had clinical. Picture. Any other questions about her? Our next patient is a postpartum.
I'll just add that, Sabai typically, for acute fatty liver, we'll say actually general anesthesia, midline skin incision. He has a nice paper on imitators of preeclampsia. I think I've shared in the past. Which is again interesting because I know that we do, spinal in the absence of coagulopathy and a fan and steel is what we typically do, but just thought that'd be interesting to share.
Great. Our next patient is postpartum. She's a 21-year-old P0111. She delivered at 32 weeks and 3 days, secondary to PPROM suspected triple I. So this patient actually presented last week with reports of loss of fluid. At that time on the 11th, she was ruled out for PPROM, but said she then persistently and continuously was leaking fluid, but because she was already evaluated, did not come back until 2 days ago. So she was seen in triage where she was found to have turbid, foul-smelling fluid with pooling, concerning for PPROM, and she also had a cerclage in place. When we evaluated her, she had also began to have painful contractions concerning for preterm labor. We attempted to remove the cerclage. It was quite embedded into the cervix, so we were only able to remove a portion of it. She underwent an epidural, and at that time, it was even more embedded, and I suspect in the cervical stroma because she had began to dilate. So we induced her, she was delivered, and then yesterday the remainder of the cerclage was removed. She is, I guess there was a decision had amongst the attending that delivered her and wanted to continue her on triple antibiotic therapy for 24 hours. So she's still on antibiotics and she's otherwise doing well. Her white count is 11.7 from 10.4. Her vital signs are stable. She's afebrile and she otherwise has no other complications. So.
What was her cerclage indication?
She was in ultrasound indicated cerclage.
No, I think she was dilated 2 centimeters.
Okay.
If you want to review the op note. So she got induced overnight. I thought she was going to go a little bit faster, but in the morning she was 8 centimeters, and after that she sort of went precipitously and had an abruption. Katie Lakritz delivered this baby, and then she called me after because she thought it was a laceration. So I came to assist her with retractions and evaluate the cervix very well. So I was afraid, I didn't cut the cerclage, and then she delivers through a colpotomy. But no, her cervix was safe. We explored and we were able to find the remainder of the Etivon string, and we removed it completely. And it was just the small lacerations where I dig in to cut the ring of the cerclage. So she got a couple of stitches, but no cervical laceration. So it still was complications of like choreo, very purulent discharge. The fetal tracing was perfect until the very end when she was pushing, and then abruption and small lacerations. Otherwise, she's doing okay, but I still kept her in our service because of this mess with the cerclage.
So I know you're studying this, Amanda, and you have a few cases and stuff, but eventually why you're going to counsel her if she wants more babies?
Oh, what do you mean? Why not? Next ultrasound, well, I believe she got a physical exam indicator cerclage. So in these cases, I tend to consult them as to have a history indicated ultrasound next time.
Yeah, it will make sense.
Let me confirm. No, I'm looking at the wrong place. Yeah, I believe it was a physical exam indicated at 2 centimeters
Yeah, fully balloons.
Yeah.
Polyballoon, yeah, it was done on July 3rd. And so I remember I tried to look into what to do next, and we normally tend to do history indicators of class for 90+% of these patients. So I still don't have a good study to say. The cases that we presented as an abstract long time ago, I believe there were few cases, 10, 15 from Gabriele from Italy, because they were doing cervical surveillance, and still 80+% of them had a cerclage indicated due to short cervix or open cervix. The most dramatic thing I have in these situations is when they have a pregnancy loss before 16 weeks, when we have not even done the first cervical length, and then the patients feel very frustrated that you didn't do anything, and now I lost another baby.
You know, these patients that deliver within a month of a physical exam indicated cerclage, I always think, you know, maybe they were infected. I don't know, Sophie, do you remember, you know, anything like, you know, the sort of ones that, you know, we consider more an amnio? You know, because technically, you know, you can put the cerclage in, you know, but the question is, you know, was she too inflamed already, maybe even infected? Oh, it was 7-2,
Yeah,
so it was
we
a while ago,
did
actually.
We did an amnio, it looks like.
It was 2 months ago.
Oh, you did an amnio, is that what you said?
Glucose was 20, and we counseled her that
And the glucose was 20,
yeah.
so it was certainly a little bit low, but not low enough.
But she still
yeah.
lasted 10 weeks after this cerclage.
Yeah.
So the cerclage
know,
was successful.
yeah, so
She was
she,
not infected at the time. She just got infected because she ruptured her membranes and stayed at home for 7 days.
you know, on the teaching side, and, you know, to kind of put it in this perspective, you know, when you're counseling somebody like this, maybe she would have lasted a month, you know, if you didn't do anything, or 2 weeks, like, you know, a little bit of time. So she was 23 weeks, 2 months. She was like 14, 15 weeks dilated that early. So she would have had a non-viable pregnancy,
Yeah,
delivery for
very
sure.
viable with cerebral palsy, which is the one I
You know, there is good data from Amanda, from many, that you prolong the pregnancy by months, maybe even some data even more, 4 to 6 weeks. But a physical exam indicated, which is almost exactly what happened in this case. But, you know, the patient needs to be aware that a successful physical exam indicated cerclage may get you a 23 week.
Yeah, we counseled her on all of that. Those are things I always try to include, or always do include, in my counseling with physical exam indicated.
Great. Jerry.
Next patient is a 32-year-old G7P3215. She's 15 weeks and presented from methadone stabilization. This patient has a history of polysubstance use disorder. Her UTOX demonstrated fentanyl, methadone, opiates, cocaine. She has a long-standing history of cocaine use. She is currently being up-titrated on methadone. On presentation, she had elevated pressures from mild range to severe range. Her last cocaine use was on the 15th. So it's a little bit difficult to differentiate whether this is a hypertensive disorder of pregnancy or hypertension in the setting of recent cocaine use. We did an extensive chart review. We're unable to get a good history from the patient. She's not really willing to converse with us. It sounds like she has 2 prior pregnancies where she presented with severe range pressures and was treated as preeclamptic with severe features, delivered around 34 weeks, but this was also in the setting of recent cocaine use. We weren't able to find any pressures when she did not present clean. She was always under the use of cocaine, so a little bit hard to differentiate. We also believe she may have a history of a spontaneous preterm delivery. Based on the notes, it sounds like she presented around 34 weeks and delivered spontaneously. At that time, she was also being managed for preeclampsia with severe features. We're waiting for her to be willing to chat with us a little bit more to get a better history, but depending on that, we may also recommend serial cervical lens. So we're still waiting to obtain a good history from her, but we started her on 30 of procardia yesterday. Her pressures improved, and then this morning I noted that she continued to have mild range and a severe range pressure, so I up titrated her to 60. Her health labs have remained normal. So we'll continue to watch her, try to get a better history, and then go from there. Jams was consulted. They have not seen her yet. We'll wait
They sent a communication, so they recommended also clonidine patch, which I added, and PRN clonidine for severe blood pressures. So we will see how she does.
Right, and that is it for our MFM list right now.
Yeah, she's also extremely cachectic with the proBNP that is elevated, and I'm concerned about long-term use with cocaine and cardiac issues. I have been surprised with cardiomyopathies and abnormal valves and endocarditis with these patients, so we're waiting for an echo.
We have a little bit of time. I just wanted to talk about our cerclage from yesterday.
Yeah, that one, Trawick. That one, okay.
I can do both, Dr. Roman.
Oh, okay, both. Okay.
So this is a patient, she's a 37-year-old prime. She presented at 20 weeks and 3 days for evaluation of initially an ultrasound indicates cerclage. She was found to have a short cervix and scans. Her cervical length was 6 millimeters. We evaluated her, she was closed. Upon exam of her vagina, it appeared extremely atrophic, similar to what you would expect from a postmenopausal patient. The posterior aspect of her cervix was also extremely flushed with the vaginal wall. It almost looked like she had a LEEP procedure, but she declines any surgeries to her cervix. So we placed a cerclage. Her end cervical length was about 2.9 centimeters, and we will see how she does. So.
Yeah, she has irregular periods. She had infertility. She's been trying for many years, but and she has symptoms of low estrogen. So it's interesting. She's 37 years old, and it looked like she's going into an early menopause. And I don't know how she got pregnant, but I'm glad she did. But
Did you do a Sherrod card?
say that again.
Did you do a Sherrod card?
No, we did a McDonald. We were able to pull the cervix and get how much we got? 18 millimeters.
2.9 at the end.
But
the total length.
posteriorly, you mentioned you couldn't see any cervix. So
It was flash, but once we placed balloon and pulled the cervix, so we got a good posterior bite. But it still is a very tiny cervix. The mucosa is atrophic, it's very smooth, very pale. I don't know if there will be any benefit of estrogen in pregnancy or just leave her alone and treat postpartum.
Again, on the teaching side, I've been doing this for a long time. I believe that that the incidence of genetically or congenitally abnormal cervix is tiny, like less than 1 in 500, really, really low. Like maybe people with Ehlers-Danlos, some people with uterine anomalies, but a cervix like that, she had this infertility history, and we infertility is great and they do a great job, but even doing hysteroscopies and workup for infertility can damage the cervix. There's certainly a lot of literature, that more short cervix, preterm births and stuff. So just something to keep in mind. Hope you can prove me wrong, because maybe it'd be easier if we had genetically abnormal or collagen diseases or things like that. And they happen, there are, like I say, collagen things. They may be innate, but I think a lot of cervixes that shorten may have happened because of prior, manipulation of the cervix. Not always, but often. Just something to, even if she denies it, I mean, she does report a history of infertility, and took her a long time.
I didn't specifically ask if she had any
Something must have happened there.
workup. We asked about surgical procedures, so maybe she had.
They were grabbing her cervix to do endometrial biopsy or whatever they were doing. Something makes it weaker.
And then on the 16th, a couple days ago, we did another cerclage. This was a 39-year-old G7P 2133. She was 21 weeks with a di twin pregnancy. She was seen at Mainline Health for her anatomy ultrasound and was found to have no measurable cervix. On our evaluation here, she was found to be 2 to 3 centimeters dilated with membranes to the external os. We performed a successful physical exam indicated cerclage. And she will follow up with us in 1 to 2 weeks for a telehealth follow-up visit, but then plans to follow up with her providers at Lankenau. All right. And that's all I have for inpatient.
I have an ultrasound from, let me see, let me share the screen.
Oh, sorry, I didn't log on to Sigma. I'm like, not gonna say you.
1 second, guys.
It'll be there. It'll be there in a second. I was like, yeah, my computer's automatically connected to Zoom.
This for situation, we have all the attendings who work at Jersey on the call, so just, there are a couple of very sick patients at Jeff, New Jersey right now. One of them is Medley, who's a type 2 diabetic, diagnosed with chronic hypertension in pregnancy at 14 weeks, started on medication, has been rapidly up titrated on medications, and is currently 3 different agents, also with new proteinuria. She's 21 weeks, I think. I saw her for the first time since her like 8-week consult last week. So aggressively up titrated on meds in the 2nd trimester of pregnancy, new proteinuria, also has an FGR baby with absent end diastolic flow. And I told her that all of those things, was 20 when I saw her. And I told her, you know, all of those things together make me very highly suspicious that you have pre-viable preeclampsia, and the treatment for that is termination of pregnancy. And she was surprised to hear that, and is not interested in proceeding with termination of pregnancy. Her blood pressures are currently controlled. She doesn't have any liver or kidney abnormalities. She's coming at least once a week to see us, and she's also seeing many other subspecialties because she had been consulted cards and nephro, trying to figure out why these things were happening. But I think that the writing is on the wall for her, especially given the FGR. The current plan is for her to come back for a repeat growth ultrasound next week on the 25th when I am there. She's 23 and 0 at that point. If she is of a gestational, an EFW at which resuscitation may be possible, I'm likely going to recommend she come to Center City for an admission, just FYI.
And her Dopplers, umbilical heart rate?
Absent. Yeah. I don't know. I think she's coming today, Moti.
Coming today at 2 p.m. Yeah. She also had, she had type 2 diabetes on insulin, which is fairly controlled. The problem is chronic hypertension with kidney disease. You had heavy proteinuria. I believe it was 5 grams.
Yeah, I don't think it's quite 5 grams. I don't remember what the 24-hour was. Her last P/C was over a gram.
1 gram in 24 hours. 7 protein in creatine ratio has been 0.7, 1.2. So it's a 1 to 2 gram proteinuria, which worsened. I don't think she had this before.
She did not have chronic hypertension before. I did her consult at 8 weeks of pregnancy, and she reported that she had no blood pressure issues. The blood pressure issues started at 14 weeks. So, I mean, yeah, I think she's quite sick. I'm glad she's coming frequently. I just am very worried about her ability to continue this pregnancy beyond, peri-viability. There's also a patient who's a type 1.
I want to bring up, when she comes in at 23 weeks admissions, one of the issues is maybe we should use the Gullersen calculator for estimating if she gets steroids or not. Moti, do you think this is a patient that we could use your expertise on and your equations and stuff to estimate her risk of delivery within a week?
Which one?
This one, 23 week, she's now 21 week, but should be 23 week FGR, absent diastolic flow.
Yeah.
Hypertension.
Yeah, no, the calculator was first developed on patients at risk of spontaneous preterm birth. We did do an analysis on our medically indicated preterm birth, but found some errors with the data. Like we have to refine that, and we work on.
They're not ready yet.
Currently, just spontaneous preterm birth.
Okay, so I'll go back to this other complicated patient in a moment, but I have a scan for a patient who presented at 13 and 2. She's a prime. She's 34 years old. Coming in for her NT scan. She's healthy, no medical problems. I'm just trying to find a good representative image for our Lachey. Lachey.
Like labeled.
Yes, it is. The arrow sign is helpful. What are you concerned about? Yeah, specifically. Yeah. So concerned about cystic hygroma. So for the learners in the room, this is a sagittal view of a first trimester fetus. We're measuring this anechoic space at the back of the neck. A normal is less than 3 millimeters. This is almost the measurements cut off, but it's 14 millimeters. And then if you look at it in transverse, which I think, sorry, this clip might not. This is transverse view of the head. So you can see it sort of protruding from the back of the neck here. You can also see additional fluid gathered around the abdomen. So cystic hygroma. Lachey, how do you, I know you haven't been an ultrasound yet. How would you, what would you tell a patient with a cystic hygroma?
Yeah, so the presence of cystic hygroma can be associated with aneuploidies. So I would offer non-invasive prenatal testing if it wasn't already completed. Depending on those results, I would also offer diagnostic testing with she's 13 weeks, so CBS, and then genetic counseling. The incidence of the aneuploidies that I'm not 100% sure of.
Anything else on, we're going to talk about the details of what you just said, but anything else on your differential besides genetic causes? That should be first on your differential, so good job. Anatomic structural abnormalities. So, Sonia, do you know the incidence of genetic conditions when there's a cystic hygroma?
It's about 30%.
Probably closer to 50% with a true cystic hygroma. And the most common are what?
Trisomy 21, 18, 14.
Turner's, trisomy 21 and Turner's. So those two are the big things. And just to clarify what you said, Lachey, you're not going to recommend NIPT. You're going to recommend diagnostic genetic testing. So recommend she undergo genetic counseling and have a CVS, right? Because anytime there's an ultrasound abnormality, you want diagnostic testing rather than screening. Unfortunately, because she was 13 and 2 and this was diagnosed on a Friday afternoon, by the time she got her genetic counseling and is able to come back for a CVS, she's going to be out of the window to get a CVS. And so I did order and send a NIPT, not because I thought that was the right test, but because I thought that might be the only test that we could get for a couple of weeks, and she won't be available to get an amniocentesis for several weeks, and she's going to be in a gray zone where I can't offer her diagnostic testing. Her NIPT just came back normal. So there are other genetic conditions that could cause cystic hygroma, you know, RASopathies are one of them, like Noonan syndrome, but certainly this is a patient for whom, you know, microarray is now will be pending when she has her diagnostic genetic testing, and who, you know, whole exome could be offered. But also you want to think about structural abnormalities, cardiac abnormalities specifically. So of the 50% who don't have a genetic condition, about 50% of them are going to have a structural abnormality, and cardiac is the most common. And so then you're sort of whittling down the population of what is normal. If you make it through your diagnostic genetic testing, you make it through your echo, you make it through your detailed anatomy, you make it through your 22-week echo, and things are normal, which again, small percentage, there's a chance that this could be a normal pregnancy, but there's also a very high risk of miscarriage in the interim. And so I counseled her that this is in Russian, which I don't speak, that this is a very poor prognosis. That this is a very poor prognosis, that she needs diagnostic genetic testing, that she's going to need multiple imaging modalities to try to understand what is going on here. So that's also in Jersey. And then in addition, there's one more patient, sorry to talk about so many Jersey.
Like also, sorry to interrupt, but I don't know what others think about this, but I've done placental biopsies and, like, you know, quote unquote CVS greater than 14, like at 14, 15 weeks. I don't know if we've routinely done that here, but again, in that setting, I'm happy to I don't know, the risk is slightly increased 1 to 2%, but if patients are interested, I know we haven't done it here, but I think that's something that is reasonable to maybe discuss and consider offering.
Yeah, I did think about that, Moji. I specifically thought about that if her NIPT was abnormal, that I would be likely to offer that to her to sort of confirm in a sooner fashion. She and her partner are very hopeful, despite the bleak picture that I've painted, that this will be a normal ongoing pregnancy. And so my concern is if I offer her a genetic test that may have more risk than our standard diagnostic test, that might not be in line with their goals. But I am going to talk to her on the phone today, so I can certainly mention that. And then there's also another patient in Jersey. Sorry for the fellows and the learners.
This is perfect. Sorry, so interesting. We have a few minutes here. It should be great for exome, or whatever, whichever way. It looked like a transvaginal, transcervical, posterior placenta thing, doing some technical stuff. But this is a patient that, just more and more data on, if you don't find a karyotype abnormality, a CMA abnormality, then you could maybe find a POM mutation or something.
Please forgive me. This is Stephanie. I just jumped on. What is the indication?
They got a cystic hygroma, Steph at 13, and she's now 14 and 1 in Jersey. She had genetic counseling with LabCorp.
Got it. And no other suspected findings at this time on ultrasound?
Correct. And her NIPT just came back low risk.
Oh, I see. Okay. Yeah, I would be definitely in agreement that that further testing would be indicated with respect to microarray and then of course exome or genome sequencing.
The last patient to mention in Jersey is and actually maybe I'll pull up her images because she's got a good ultrasound finding too. You guys haven't talked about her. She's a type 1 diabetic who presented late to care at 20 and change in DKA in New Jersey. She has significant social barriers to care. She's homeless. She does not have insurance. She does not have reliable transportation. She does take insulin on a regular basis, thankfully in the setting of her type 1 diabetes, but she otherwise is really absent from care. She came in again initially in DKA, and then we brought her in for an anatomy scan, which was not normal. Her A1C at the start of pregnancy, or by the time we saw her in pregnancy, was 10.6, which is associated with I love to talk about this. What's her risk of a genetic or an anatomic abnormality with an A1C of 10.6? What's the percentage? How likely is she to have a major structural anomaly? 25%, yeah. And the most common is cardiac. The most specific is what? Sacral agenesis, right? So it's not the most common, but it is the most specific for diabetes. Okay, she doesn't have either of those things. She has something else. So let me find the picture for her. I'm currently working on trying to get her in for a pediatric consult at any location. It's made very challenging by the fact that she now has New Jersey Medicaid, but she doesn't have reliable access to transportation. And so some of the places that we typically refer are not accessible to her, and arranging transport from some of those places that I do not work is obviously a little more challenging. Sorry, just want to find it. Oh, this is her echo. This is You guys didn't talk about this patient with ruptia, right? In the last 2 weeks? I don't think so. Okay, great. I'm just trying to get the scan to come up. Sorry, my computer has. Don't apologize. I came unprepared. Okay. It's happening. All right. What do you see, Kamisha?
So we're looking at a transverse view at the level of the thorax. I'm looking at a hyperechoic area, what looks to be in the lung fields. Heart, looking at just cardiac looks to be maybe a little bit deviated, but really the biggest thing that I'm pointing to is that area that's a little hyperechoic. When I think about etiology or differential for masses in thorax, I'm thinking CPAM, for instance, thinking about bronchopulmonary
Sequestration.
BPS, which I know involves on a spectrum. Also thinking of, it doesn't look like a fusion, but those are other things you would think about. Chaos,
Congenital high, airway obstruction sequence where
higher up.
it makes the whole lungs look echogenic.
TEF, that doesn't appear to be that, so more of probably CPAM or BPS. You could differentiate by putting color. And so with CPAM, for instance, that has to do more with dysplasia at different parts of embryogenesis of the lungs. So it doesn't have to do with blood vessels, versus UPS has to do more with systemic feeding of the blood vessels from the aorta. So you would want color, and if you see systemic blood vessels, think BPS, but a lot of the times these can occur simultaneously. So
yeah, it's not always as straightforward as we would like to make it believe, but in the traditional teaching is that CPAM has has blood supply that comes from the pulmonary artery or branch of the pulmonary artery, and that a BPS has a blood supply that comes from the aorta, as Kavisha said. So we put color flow on. I think the color flow, I'm not going to show you the color flow picture, but the color flow looks like it's coming from the pulmonary artery. So leaning towards CPAM versus BPS, though again, sometimes these are tricky. So what's one additional thing we could do to talk about prognosis for this patient?
You look at the ratio of the mass to the abdominal to the head circumference. If it's greater than 1.6 in the absence of high drops, then you think about a worse prognosis, versus if it's in the setting of high drops and it's greater than 1.4, that's when you associate.
Yeah, so the Kavisha's talking about basically calculating a CPAM volume ratio, a CVR, and a CVR greater than 1.6 is associated with a higher risk of high drops and worse prognosis. If you're between 1 and 1.6, those are patients who may be still at higher risk of high drops, and so you may want to increase your surveillance. If their CVR is less than 1, they tend to be at lower risk of high drops in pregnancy. This patient's CVR was like 0.4, so quite low. But she still needs counseling, right? Because
how many weeks is she?
She's 25 or 26 now.
Should you know when they
rapid
the
growth.
most, or what's the natural history?
So
Since
it
you're
can
talking, sorry.
regress.
Uh-huh.
It can regress and change, and I believe it's dependent on I may be mistaken. I remember Mr. Dr. Bull gave us a lecture on it. But that was like sometime earlier last year.
It's really important to remember they usually peak into growth around this time, 25, 26, some people say 28 weeks.
Afterwards, it can.
And afterwards, the baby's growing, and usually the lesions tend not to grow, so the ratio gets smaller. So the risk of high drops and baby dying and etc. Really happen before mostly again 26, 28 weeks. So the fact that the CVR is 0.4, 25 weeks is very assuring.
And it's
probably not related to diabetes.
It's like an overall diagnosis, is my understanding, for
fetal
this
life,
specific situation too.
And there are a lot of different types of, the other thing that we didn't really touch on is there are different types of CPAMs. And so this, may be more like a microcystic CPAM, given that it's, I don't know, honestly, I have to always look it up. I usually just describe it. So I would say this is like more microcystic because it's uniform and hyperechoic, but I showed a CPAM, a couple of months ago that was mostly like large anechoic cysts, and those are slightly different, and having a very large cyst, even if the CVR is normal, can be associated with sometimes a worse prognosis, but this obviously is not the case. The issue postnatally with these lung masses is sometimes, initial difficulty with respiration, though less so if the mass is small, but more that they get chronic infections. And so that this is generally something that needs to be, evaluated and removed, though not always necessarily at the time of delivery. This patient with her severe type 1 diabetes is not going to be a candidate for delivery at any of the fetal centers. And so trying to get her locked in with a pediatric surgeon to talk about the prognosis is important, but then trying to figure out where she's going to deliver to be able to get her baby transferred for evaluation postnatally is going to be something else. So more to come on her. And then there's another patient in Jersey that I don't have time to talk about who's less interesting than the 3 people I just brought up.
And I know Moti wants to talk about that, or somebody wants to talk about the pubs.
Yeah.
Yes, I have that. Sorry, also pulled up 1 second.
We have like 3 minutes, right? So I don't know if that's.
Yeah.
I can do it pretty quickly. As a summary, we can talk more, but this is Sarah Weistrick, who's a 39-year-old G11 P8, who was essentially here for a second consultation in this from Monmouth. She has a history of alloimmunization. Her 4th, 5th baby required transfusions postpartum, multiple transfusions postpartum. 5th baby also required multiple transfusions postpartum. And her last pregnancy in 2023 did involve 2 pubs with no postnatal transfusions. In this pregnancy, she obviously has known alloimmunization, has been closely followed with the maternal fetal medicine providers, RHD.
Okay.
Yeah, big D.
And we know the husband is homozygous, or?
That I don't know. I couldn't see it in the record, so I'd have to.
From the history, sounds like it's.
It sounds like he is, yeah. But she's been following with the MFM team at Monmouth, and then last week, so when she was 27 and 5, her the highest MCA Doppler was 1.7. They repeated it on the 16th when she was 28 and 5, and it was 1.5. Given this elevation, she was referred to see us, and we saw her yesterday. We did a high drops evaluation, including an MCA Doppler. There was no signs of fetal high drops. The cardiac circumference, thoracic circumference ratio was 0.54. The liver length was increased. It was 4.93, and the range is between 3.44 to 4.24 at that gestational age, so slightly increased. In terms of the MCA Doppler or peak systolic velocity specifically, the measurements, only 2 out of the 7 were elevated. And it was 1.50 MOMs and 1.52 MOMs. So given this overall picture we discussed with her, obviously that MCA Doppler has a very high sensitivity, but there's also a false positive rate of 12%. And then given the overall reassuring Dopplers that we've seen, at this point, we would hold off on proceeding with the pubs. That said, given her history and the fact that we're seeing this in large liver, she's at very high risk of this recurring and need for transfusions. So she is going to be presenting on Monday when Dr. Al-Kawali is on. And so we will be repeating this entire process again. To further
Who's going to do the pubs with me next week?
Mm-hmm. Well, I'd love to do it.
No, just asking.
We
know where we're
going. We will later.
She is an Orthodox Jewish person who is observant of Rosh Hashanah, which is next week, which further complicates things. So we did speak to her. We actually spoke to her, in the setting of a life-threatening situation, which her rabbi would let her, but we kind of already had her start that conversation with her rabbi and her husband, so that is when she comes on Monday, she knows the possibility is either she spends the night at Jefferson, she can go home and come back early Tuesday morning, or we have her follow up again on Thursday.
That's a no, so
Hi. Can I, I'm sorry, there's a patient here I have to see also with an increased NT, but Sarah called me about 20 minutes ago. She's asking, apparently this is really hard for them to do this on Monday and Tuesday. It's extremely hard. It's very complicated in their religion. unless this is like a really an emergency that has to be done. So she was asking, is there any way that it kind of either, she wanted to know first, could she come in early Monday morning? And if there's a pubs, can we do it later in the day? I don't think that's possible because of blood. I'd have to ask the blood bank. Usually their blood comes in from New York overnight. She asked if she could come in Sunday for evaluation.
In-house this Sunday.
She asked if she could come in Sunday. Is there anybody that could evaluate her on a Sunday and see and plan from there? She asked, I guess, if we, yeah. So I don't know. And
Wednesday, I mean, the only thing, no, none of those would work.
right.
The only thing if she takes the risk of
Yeah. I mean,
or an making coming.
I think they'll do what they have to if they really have to. But she said, in her words, it's very complex, and it's not without its issues, I guess, for them. So she also, I had asked, and Modi had let me know, but I had asked if there's, I don't know if it's worth her coming back tomorrow and then seeing what, and then maybe trying to plan for something for Monday. I mean, yeah.
We didn't think there would be much of a change between.
I think that's also complicated by the fact that if something goes wrong, or she needs observation in the hospital, she's not going to want to stay because of Rosh Hashanah. So I don't know if we should even plan to do a procedure on Monday.
She was willing to, when we had the conversation.
No, she's willing to Monday. She said if there's any way she can come in early and the pubs could be done like later in the day.
I think Sophie's point is that if there's a complication of an afternoon pubs and Rosh Hashanah starts at sundown, is she going to be willing to remain?
Yeah, I mean, I'd have to ask her. That's a question. I don't know. Maybe if she's already here, then it can be accepted. I don't know. My only other thought was sometimes I remember that we've done this where like patient comes in, like if we see her Friday and we're not sure, that she comes in Monday morning again here in the office for another scan. And then, but we set up as if we're going to do the pubs Monday. Like if the scan looks like she needs it Monday morning, we'd be ready to go Monday. I know we've done that in the past,
But
but
you don't think that, okay, let's start, philanthropic, we can talk about this offline
okay,
as
sure,
well. But
sure.
I mean, it's all really up to you, Alex, as well. I don't know if the blood bank, would be ready, even if she comes at 8:00.
No, it would be have to plan. It would almost be like we'd have to say to, like if she came tomorrow and we looked again, we'd have to say tomorrow to the blood bank, we need this for Monday. So they would prepare over the weekend to get us blood for Monday. And if she comes in Monday morning and it looks still good, we would just cancel that.
I would, for now, I would tell her we would like to treat her just like anybody else around your religious beliefs as well. And she can, if she's willing to come on Monday morning for the ultrasound, I think that was decided and that's the best thing. And then we'll go hopefully be, the same as before. If not, I think she needs to know the issues and then she can make the decision. But I think I will keep the same plan with you guys.
Okay, so just stick to what we planned yesterday, coming in Monday morning and going from there.
Because I think having her come on Friday makes absolutely no sense because we'll probably want to change anything. And then Monday, if it may be that Monday we don't even need to do anything. So
it's bad that it does become a life or death situation.
Yeah. And we did explain that to her also.
Should we do it?
Okay.
Sorry.
No problem. Why don't we move to ICN updates? I saw ICN. They're eager and willing, Amy.
Good morning. How are you?
Go ahead.
All right. It looks like you guys had just 8 patients on the ICN list. So well, I can go through quickly. So baby Close, boy Tori Close. He's 90 days now, 91 days old. He was born in 25 and 4. This was a very precipitous vaginal delivery with placental abruption. He needed quite the bit of resuscitation in the delivery room. But he has done well. He is newly on nasal cannula as of yesterday. He has evolving BPD, but he's improving. He is still primarily NG feed dependent, but hopefully now that he's off of positive pressure, he's going to be able to start working on oral feeds. His history has been complicated by medical neck about a month and a half ago, 2 months ago. And he thankfully did not need any surgical intervention. He's done well with enteral feed since then. Neurologically, he did have a right grade 4 and a left grade 2, which have sort of started to improve, no hydrocephalus. And he did undergo laser therapy for his retinopathy. That was on September 3rd, and his exam is improving. So all in all, right now, he continues to remain hospitalized for our respiratory distress, I guess now BPD and feeding immaturity. But he's 30 weeks corrected, so he's moving right along and doing relatively well. The next one is baby boy of Megan Dubel. He was a 29 weeker. This was a very medically complex mom, as I'm sure you guys know better than I, with a history of pancreatic and renal transplant, chronic kidney disease. Baby had high drops of bilateral pleural effusions and ascites. He was delivered at 29 and 3 for non-reassuring fetal heart tracings after an amniocentesis. He is now in room air as of 3 days ago. He was previously ventilated for some time, but he's been extubated for over a month now and doing well. The reason he remains hospitalized still is just for feeding immaturity, but he's starting to take almost all of his full bottle. So he's getting fairly close to discharge. He's had no reaccumulations of his effusions once initiating feeds. His chest tubes have been out for a long time. Neurologically, he has not had any IVH, just some asymmetric kind of thickened choroid plexus, and he's had no retinopathy. And I believe genetics so far has all been reassuring. Next I have baby Finette Silva, who was just born yesterday, Maria Finette Silva. 32 weeks, delivered after prolonged PPROM with, it sounds like probably confirmed choreo based on the amnio. The baby is doing really well, 32 and 3 with 1690 grams. I think needed just a little bit of CPAP in the delivery room, or actually PPV and CPAP in the delivery room, but has been in room air here since admission. Is just on TPN and has started some tube feeds. So far, we have not had any growth on our peripheral cultures, although he's on antibiotics empirically. And he looks really good. Baby girl of April Gordon. This was our extremely tiny 25 weeker, I believe. So I'm just trying to find her on here. 390 grams, I believe, was her birth weight. 350 grams, even smaller. She was 24 and 2. She is old now. She's 97 days. She had a course complicated by a suspected esophageal perforation in the beginning that was that has since resolved. She has been extubated for some time and is now on CPAP. She does have BPD and obviously remains on CPAP, but is slowly starting to wean. She remains on all tube feeds due to her respiratory status. She's also had numerous other kind of endocrine and metabolic issues, most significantly adrenal insufficiency, just due to her prematurity and size and critical illness. But she has been able to be weaned off of hydrocortisone. She has had no IVH, and she is sort of on the borderline as far as developing ROP, where she may need treatment with laser in the next week. She has already received bilateral Eylea injections last month. But otherwise, I still expect she'll be here for quite some time. I probably at least another month. But given her extreme growth restriction, none of this is surprising, and she's doing relatively well. Baby Kier's, this was a 27-weeker, is now 57 days old, corrected to 36 weeks. He was delivered via C-section for maternal preeclampsia with severe features. This was a mom who had no prenatal care, and there was some alcohol exposure throughout pregnancy. Baby's done well, never intubated. He's been in room air now for a couple of days, is taking all his feeds by mouth, and he is actually getting ready to hopefully go home later this week. He's had no retinopathy, and his head ultrasounds have just shown a left-sided grade 2 IVH. And socially, I believe he will go home with mom. I'm going to save baby Night till the next OBCC meeting. In short, just because she was transferred out to Nemours yesterday for BPD management and evaluation for possible tracheostomy. So I'll save her for our discharge patients, just in the interest of time. Baby Malera, Emily Malera, he's 74 days old. He was a 25-weeker, now 35 and 4 corrected. This was a mom who was PPROM'd for almost a month prior to delivery, triple I, C-section. Surprisingly, his pulmonary status has been, I think, better than anticipated. He was able to be extubated without significant difficulty fairly early on in life with the help of some dexamethasone. He's now on nasal cannula as of yesterday and doing well. He is on tube feeds, although hopefully we'll start to take some oral feeds in the next week or so. He has had no IVH and does have stage 2 retinopathy that has not required any treatment. And lastly, baby girl Tar. This is the surviving twin of Elena Tar. She is 43 days old. She was born at 25 and 2 after PPROM. Her brother passed away about 2 weeks ago due to pulmonary hemorrhage and pulmonary hypertension, although the inciting factor for that is still a little bit up in the air. But his sister is doing well. She was extubated about 10 days ago and doing well on non-invasive ventilation. We're moving really slowly with her just because some parental hesitation to make really big changes. And also they've had a really difficult week with the brother's funeral. And also, unfortunately, this is the anniversary of the older siblings passing. So this is quite a terrible week for them. So we want to make really kind of no big changes this week and just make sure that she remains stable. But she is overall, she's progressed well. She is feeding via tube feeds. She is has had no IVH. She just has stage 1 ROP. And then the only other thing is she's had some inconclusive newborn screenings for congenital adrenal hyperplasia. Although all her electrolytes and blood pressures and everything have been normal, so it's probably just a false positive related to prematurity. So the confirmatory testing is, which is a send out, the 17-OHP is still pending, but we don't have any clinical suspicion that she has CAH. That's it for my list
Amy, can I ask about one other patient? Sorry, I might not know how to put people on the list properly. Abby Carter, baby girl Abby
Yeah.
Carter, the
Yeah.
21.
Oh yeah, absolutely. I'm surprised she wasn't on here. That's a big one that's on here. Yes, so as you know, 22 weeker. She's 54 days old now. She's had a tough course. She initially did well on relatively low vent support for a 22 weeker. But unfortunately developed MRSA bacteremia at about 3 weeks of life, which unsurprisingly really set her off into uh, developing much more significant lung disease, and she's been on really high respiratory support. She also, as a result of this MRSA bacteremia, has probable right hip osteomyelitis. So she's been on a very lengthy course of vancomycin, although she should be actually finishing up her treatment this weekend. And unfortunately, because she has been infected, we have not been able to utilize steroids to help manage her lung disease. So her respiratory instability has been a little bit difficult to manage. So we've actually had to keep her really heavily sedated and paralyzed, paralysis is not typically common for us and these really little guys. And also some inhaled nitric oxide for some clinical suspicion of pulmonary hypertension. In the last couple of days, she has been more stable with weaning of IO2 requirement, but again, it's really taking a lot of sedation and paralysis to get her there. So we are hopeful that next week, once she's finished her antibiotics, we'll be able to consider some steroids to help with her lung inflammation and hopefully be able to wean some of her respiratory support and thus wean some of her paralysis. Neurologically, she actually has had no IBH, just some kind of linear echogenicities suggestive of some possible PVL. And then she has been seen by ophthalmology, and I don't believe she is starting to develop any ROP yet. Actually, no, I'm sorry. That is a lie. She has not been seen by ophthalmology yet. She's too young. So I think now that's it. I'm sorry. Is there anybody else who wanted to know about?
Hi, I was just wondering if you could talk about baby Munari. Mom was Eden.
Yeah.
Thank you.
Sure. So baby Minari was about a month and a half old. So she unfortunately passed away last week. Had always been a relatively sicker, and I'm sorry, I can't remember, 24 or 25 weeker, I think 24 weeker. And never really been successfully extubated. We had some very brief trials, but had ended up getting reintubated. And last week, just really developed some subtle clinical changes, some tachycardia, riding the ventilator. So the overnight team had gotten a blood culture and some screening labs, started antibiotics for sepsis evaluation, and just very quickly went from 0 to 100, deteriorated with hypotension and urea, kind of purpuric changes, ended up on several pressors, was completely encephalopathic. The blood culture grew E. coli. So despite really early initiation of antibiotics, even from like the most subtle clinical changes, we just could not get in front of it. So I think from blood culture initiation of antibiotics to her death was less than 24 hours. The parents ultimately decided to redirect care when we really knew that there was not much that we could not much more that we could offer. So they chose to redirect here and able to hold her in the last couple of hours. But yes, ultimately the diagnosis was E. coli sepsis with multi-organ failure.
Thank you for sharing.
Yeah. So very sudden and just began very, very subtly and just from 0 to 100 very quickly.
Thanks for all those updates. We're going to move on to field therapy. And Sonia Biswas is one of our fellows is going to present on abdominal wall defects, part one of, okay. It is a huge topic. There's actually a lot of e-talk about this as well. And yeah, go for it.
I am Sonia. I'm one of the second-year fellows, and I am going to be talking about abdominal wall defects. So here's the outline for today's talk. First, we'll review some embryology, we'll discuss the background, we'll talk about the epidemiology, and then we will go into prenatal detection and some specifics regarding the different types of abdominal wall defects. All right, so everyone's favorite topic, embryology. On the left is an illustration of an 18-day embryo. And at this point in time, the roof of the yolk sac becomes incorporated in the form of a tube as part of the primitive gut. The cranial end of the tube becomes the foregut, and the caudal end becomes the hindgut. On the right is an illustration of a 4-week embryo, and the pharynx and lung bud arises from the foregut along with the stomach. The allantois connects the body stalk to the hindgut, and then the yolk sac communicates with the primitive gut. And errors in development of this communication is what leads to things like TEF, so tracheoesophageal fistula. And then next comes bowel rotation. The primary gut begins to elongate along the dorsal mesentery, and the hepatic diverticulum gives rise to the biliary tree and pancreas. The arterial supply is already defined, so you have the celiac artery for the foregut, the superior mesenteric artery for the midgut, the inferior mesenteric artery for the hindgut. The liver continues to enlarge, and only the caudal part of the ventral mesentery will remain. The dorsal mesogastrium elongates, and then the gut continues to elongate and rotate counterclockwise around the SMA within the dorsal mesentery. So common developmental disorders during this phase includes mid-gut malrotation, omphalocele, which we'll be talking about, as well as an imperforate anus. So now at 12 weeks, the small intestines have returned to the abdomen. The yolk stalk, which is connected to the yolk stalk, which is connected to the yolk sac and primitive gut, begins to disintegrate. And then the cecum is the last part of the intestines to return. And this continues to rotate in a counterclockwise direction until reaching the right lower quadrant. And by 4 to 5 months, the colon is completely fixed in the retroperitoneal location. And the small bowel and transverse colon remains intraperitoneal and are suspended by their mesenteries. Sorry, I just skipped a couple. All right, so the most common abdominal wall defects include gastroschisis, omphalocele, ectopia cordis, and bladder exstrophy. The gastroschisis, ectopia cordis, and bladder exstrophy are classified as ventral body wall defects, and these are likely caused by the abnormal closure of the lateral body wall folds that approach each other in the midline and then close by the end of 6 weeks. So omphalocele occurs when there is a failure of the physiologically herniated bowel loops to return from the umbilical cord to the abdominal cavity by 12 weeks. So remember in the previous slide, we talked about how the intestine should then return by 12 weeks. So a little bit about the epidemiology. The EuroCat network, which is a registry that monitors congenital anomalies, evaluated for gastroschisis and omphalocele. They included European registries from 1980 to 2011, and they determined the following prevalence of each of these. So the prevalence of gastroschisis was about 3 in 10,000 births and about 2.6 in 10,000 live births. The prevalence of omphalocele was about 3 in 10,000 births and 1 in 10,000 live births. So you can see a chart here, which demonstrates the prevalence of gastroschisis did appear to increase from 1980 to 2011. So this right here is gastroschisis, and this right here is omphalocele. So you can see that omphalocele, which are mainly genetically determined, and some evidence suggests that it can be caused from poor socioeconomic status, and teratogens may contribute to the development of gastroschisis. A similar trend for an increasing prevalence of gastroschisis has been reported in North American populations, which involves pregnancies from younger women of non-Hispanic white populations. And some of these known teratogens are from NSAIDs, Tylenol, and pseudoephedrine. So just to summarize here in this chart, omphalocele increased and gastroschisis increased, and omphalocele appear to remain stable over that period of time.
Some of this data, it's a little bit old, obviously, going up to 2010. It really has followed, gastroschisis has followed teenage pregnancy trends, and they have decreased in the last 15 years since 2010. So that enough, the incidence for gastroschisis is also kind of tapered off, at least the same. It's not continuing to increase only because there are less teenage pregnancies.
A slide for that as well.
Sorry.
That's okay.
Shut up.
So again, the EuroCat registry reported the following regarding chromosomally normal cases. So 22% of chromosomally normal cases of gastroschisis were diagnosed before 14 weeks, and 50% were diagnosed between 14 and 23 weeks. For omphalocele, 35% of chromosomally normal cases were diagnosed before 14 weeks, and then 30% were diagnosed between 14 and 23 weeks. The overall prenatal detection rate for gastroschisis was 91%, and omphalocele was about 83%. So going into more detail regarding prenatal detection, an important trend to note is that the anticipation of prenatal diagnosis of these abdominal wall defects are easily diagnosed between 11 and 14 weeks on a nuchal translucency scan. Senegalaki et al. Evaluated the performance of the 11 to 13-week ultrasound in detecting those with non-chromosomal abnormalities. This prospective study included more than 45,000 pregnancies and reported a sensitivity of 100% for both abnormalities. Then there was a systematic review by Rossi et al. That evaluated the efficacy of early ultrasound between 11 to 14 weeks to identify fetal malformations. So this review included 75,000 fetuses and reported a sensitivity of about 90% for abdominal wall malformations. So now I'd like to dive a little bit deeper into a few of the malformations. Today I'll be reviewing gastroschisis, body stalk anomaly, and bladder exstrophy. And then in October for part 2, I'll review omphalocele, pentology of Cantrell, and cloacal exstrophy. So first we'll discuss gastroschisis. So gastroschisis is derived from the Greek words gaster, which means belly, and schisis, which means cleft. So this is a full thickness, right-sided, peri-umbilical abdominal wall defect that results in the herniation of abdominal structures, such as bowel, outside of the fetal abdominal cavity, exposing the organs to the amniotic fluid. It occurs early in embryologic development at around 6 to 10 weeks after conception. And here on the right is an image demonstrating this defect, which you can see is to the right of the umbilical cord insertion. So the exact pathogenesis is unknown, but various theories have been suggested. Some believe it may be due to the failure of the mesoderm to form the body wall, perhaps due to the rupture of the amnion around the umbilical ring, abnormal involution of the right umbilical vein, leading to weakening of the body wall, abnormal body wall folding, some gene polymorphisms, maternal immune response to new paternal antigens, and then use of medications such as aspirin or pseudoephedrine in the first trimester. So as I had previously discussed, based on the EuroCat network, the prevalence of gastroschisis did appear to be rising, but in a more recent published study, Mustafa et al. Reported some data that suggests that the prevalence is actually decreasing. So she performed a retrospective analysis of about 6,800 isolated cases of gastroschisis, and these live births occurred between 2014 and 2022. So they found that in 2013, the prevalence was 2.86 out of 10,000 live births, and in 2022, this decreased and was 1.55 in 10,000 live births. So the authors attributed this to the declining birth rates in those that are high risk, as Dr. Brigilla had mentioned, so people who are young, teen patients, those that are underweight, and those that smoke. They also concluded that given the recent legislative actions that limit or eliminate reproductive health care access, we may begin to see an increase again. So I thought that that was a very interesting point that they had made. So to review some risk factors from gastroschisis, maternal age less than 20, cigarette smoking, drug use, alcohol use, low BMI, and, which I found very interesting, a first trimester UTI. One large study reported that those that are less than 20 years old were 7 times more likely to have an infant with gastroschisis when compared to those that were between the ages of 25 and 29. So now we'll go into how we diagnose this prenatally. So the early ultrasound findings are as follows. You would see para-umbilical abdominal wall defect, intestinal loops that are protruding through this defect. That's right of midline. The stomach may be dilated or herniated through the defect, and you will also see free-floating intestines due to the lack of a covering membrane. The late ultrasound findings include the thickened matted bowel wall due to chronic exposure to the amniotic fluid. Oligohydramnios is the most common amniotic fluid abnormality. However, polyhydramnios can also be seen given the potential for bowel obstruction, such as intestinal atresia or reduced bowel motility. Elevated MSAFP secondary to the increased passage of alpha-fetoprotein from the fetus to the abdominal fluid via the defect. And gastroschisis is associated with higher levels of MSAFP compared to omphalocele or other neural tube defects. So here are some images of early ultrasound findings. So here on the right, this is a 13-week ultrasound, and you can see this herniated bowel through the abdominal wall. So here is the abdominal wall. You can see that the amniotic fluid is separating the bowel, which indicates that there is a lack of a membrane that's covering. The corticine inserting on the abdominal wall here, and this defect is median. The image on the right also demonstrates an abdominal wall defect, and the arrow is pointing to the SMA, the superior mesenteric artery, that has also herniated. And then these are some images from ultrasounds later in pregnancy. So on the left here, this is the abdominal wall. You can see that this is the defect here with the intestines outside. And inside here, with the internal intestines, you can see that the intra-abdominal bowel is dilated. On the right here, you can see that this bowel is matted and it's no longer, well, we can't see it here, but it would not be moving as freely as something that did not have this matting. The bowel wall thickness and echogenicity are increased, and this is likely secondary to exposure to the amniotic fluid. So now we'll go into some genetics related to gastroschisis. Chromosomal abnormalities are rare in gastroschisis. One study by Abdullah et al. Performed an analysis which included about 4,000 infants with gastroschisis, and the authors reported that only 0.1% were found to have an abnormal karyotype. Another study by Stoll et al., which included 60 patients with gastroschisis, demonstrated that only 1.7% had a chromosomal abnormality. And of note, neither of these two studies were of isolated gastroschisis. So in a large study in 2007, Mastrio, Acavo et al. Found that 14% of cases of gastroschisis had an additional anomaly, more commonly cardiac, cranial, and renal. And only 1.2% of these were the result of a chromosome abnormality, although an underlying copy number variant or monogenic disorder may be responsible. So later, a systematic review by Marquardt et al., which was published in 2024, continued to evaluate the genetics of gastroschisis. 14 studies were included, and they mainly assessed for these specific genes that are listed here. ICAM1 was the most common one that was identified in these studies. Included in this review was a copy number variant study that evaluated the karyotype and microarray data of about 4,000 individuals that underwent a CVS, so a chorionic villus sampling, or amniocentesis. About 1,000 of these fetuses had an anomaly that was detected on the ultrasound scan. And only one of these patients had a copy number variant that was notable in the abdominal wall defect group. And of note, there was 40 of these patients, so 1 in 40. However, there was no significant correlation between this abnormality and then the observed copy number variants. The results of this systematic review continues a theory that gastroschisis is likely caused by this gene-environment interactions. And while a monogenic etiology has yet to be identified, it provides insight into some genes proposed to be involved in the etiology of gastroschisis, specifically ICAM1. So now we'll go into some associated anomalies with gastroschisis. The associated congenital anomalies range from 8 to 24%. Gastroschisis is typically associated with gastrointestinal and genitourinary anomalies, such as malrotation, atresia, stenosis, superior mesenteric artery disruption, gallbladder atresia, and bladder herniation. In some rare instances, it is associated with amyoplasia, which is a rare disorder characterized by joint contractures. So here on the left, you can see a fetal bladder that has herniated through the defect. This is the bladder right here. The defect is paramedial to the umbilical cord insertion site. And then here on the right is a 3D image that demonstrates severe extension of the lower limb. So this is the leg going up. And you can see that there's severe extension and these toes are pointing, all concerning for amyoplasia. The pregnancies complicated by gastroschisis are at high risk for adverse perinatal outcomes, including fetal growth restriction, oligohydramnios, polyhydramnios, and spontaneous preterm birth, as well as stillbirth. Fetal growth restriction is found in 30 to 60%, and oligo is seen in about 10 to 25%. While polyhydramnios is less common, it does suggest a proximal obstruction and is associated with bowel atresia. So one important challenge to note is measuring, or how do we measure an AC in a patient with gastroschisis or any abdominal wall defect, because the AC will be significantly smaller. So Chaudhary et al. Performed a retrospective study of fetuses with gastroschisis, and they performed an EFW, so fetal weight, within 2 weeks of delivery. They reported that the Hadlock formula relies heavily on the AC and therefore underestimates the fetal weight. Simer and Shepard had the lowest percentage of errors. Cymer does not include the abdominal circumference, and the Shepherd formula moderately weighs the AC. So therefore, this study concluded that the Shepherd and Cymer formulas were the best at accurately predicting birth weight and reduce the overdiagnosis of fetal growth restriction. More recently, Ha et al. Performed a retrospective study that included 112 cases of abdominal wall defects, and the Hadlock formula demonstrated accuracy comparable with previously established margins of error. So the standard EFW assessment with Hadlock formula remained an appropriate method in assessing fetal weight in those with gastroschisis and omphalocele, and I believe this is what we're still using in our ultrasound unit today.
Can we exclude the bowels?
Yeah,
You're
we
just measuring the regular AC that you would normally measure, yep.
So now we'll talk a little bit about complex gastroschisis. So this is a severe form that's found in 10 to 15% of patients. And a meta-analysis in 2020, or a meta-analysis of 2023 fetuses with gastroschisis found that intra-abdominal bowel dilation and polyhydramnios detected on prenatal ultrasound was associated with bowel atresia. And remember, this is typically a later finding. The subsequent accumulation of amniotic fluid causes dilation of the proximal bowel and ultimately polyhydramnios. So patients with bowel atresia are classified as complex and have a more complicated postnatal course. Bowel atresia typically occurs at the level of the small bowel, and the intra-abdominal bowel is considered dilated when the luminal diameter is greater than 6 millimeters. And when it's greater than 14 millimeters, it's associated with increased rates of atresia. Extra-abdominal bowel is considered dilated when it's greater than 10 to 15 millimeters. And here is the same picture I showed before. I just thought it demonstrated it really well. You can see all of this dilation here. And this is a sign of this complex gastroschisis. When you're comparing intra-abdominal versus extra-abdominal bowel dilation, it's the intra-abdominal bowel dilation that's more predictive of the complex gastroschisis. So some experimental animal studies on animal models did demonstrate that clearing of the amniotic fluid by amnio exchange was found to reduce the inflammatory process of this condition. So this RCT evaluated the benefit of amnio exchange procedure for fetal gastroschisis, and they included 8 referral centers, which included a total of 64 patients. The amnio exchange was started at 30 weeks. It was repeated every 2 weeks until delivery. So under ultrasound guidance, they removed 300 cc's of amniotic fluid and then replaced that same volume with warm saline. And this exchange was repeated up to 3 times. Ultimately, they found that there was no significant difference in the outcomes between the control group and the amnio exchange group. So simple gastroschisis has a good prognosis. The survival rate is 100%, whereas when there is complex gastroschisis, the survival rate is of course lower, about 70%. If there is liver involvement, the prognosis is grim. And this picture here demonstrates this liver, which is here, herniation of the stomach, and then both the small and large intestine. And again, this type of gastroschisis, the complex version, is typically not compatible with life. Now, timing and mode of delivery. Fetuses with gastroschisis can be delivered vaginally at or near term. Some have advocated for a planned preterm birth between 36 and 38 weeks, but the evidence reported varies and there's conflicting results. Most report a mean gestational age at spontaneous delivery between 36 and 37 weeks. And studies on mode of delivery are not conclusive and did not show any consistent advantage between either modality. So regardless, care must be taken during delivery, regardless of the mode, because both can be traumatic. Delivery at a tertiary care center with a neonatal intensive care and pediatric subspecialties are necessary. And here's another image of a neonate after delivery. You can see that there's dilation of some of the bowel, and then this is the bowel that's not dilated. And typically after birth, they'll place a nasogastric tube, so when the baby's crying, it doesn't cause more dilation. All right, so how do we manage these neonates after birth? So the exposed bowel loops can cause significant water loss by evaporation. So after delivery, IV fluids are immediately started. The herniated bowel loop should be wrapped in warm saline-soaked gauze. They should also be the exposed content should also be covered in plastic wrap to reduce the loss of water and heat. And then the newborn should be positioned on the right with packed bowel placed centrally on the abdomen to avoid kinking of the mesentery. So remember, this typically occurs on the right side. So if you put the baby on the left, all the contents are going to fall to the left, and this can increase the risk of mesentery kinking. So the ideal treatment is primary reduction and repair by immediate repositioning of the herniated bowel back into the cavity with closure of the abdominal wall. If the newborn is unstable or the reduction is not possible, staged repair is preferred. So this consists of applying a plastic silo. And here you can see this silo is this plastic bag here, which is placed around the bowel, and it progressively will push the bowel back into the abdominal cavity over days until this definitive closure is possible. When bowel atresia is present, primary anastomosis is often impossible due to the bowel thickness. So they will use the silo for a short interval, typically less than 5 days, and it has similar results to the primary repair cases. So here, this top picture is early on with use of the silo, and you can see here that it's been able to progressively place the bowel back into the abdominal cavity, which I think is amazing. So now I wanted to switch gears and briefly talk about some other less common abdominal wall defects. So next I'll talk about a body stalk anomaly. This is characterized by herniation of the abdominal contents into the extra embryonic colon through a large wall defect and by a short or absent umbilical cord. So this is typically a lethal diagnosis. And in early pregnancy, the upper part of the embryo is seen within the amniotic cavity, and then the lower part is seen outside of it. Later in the pregnancy, the umbilical cord is either short or absent, so you can see that the fetus is stuck to the placenta. And it's associated with other anomalies such as scoliosis, cranial and limb defects. And in this image, you can see this is the placenta here. This is the abdominal wall defect, and you can see all of these contents are attached to the placenta. Because the body is attached to the placenta, the baby is not able to move freely, and you can also see here there's scoliosis. So these are some images that demonstrate the early ultrasound findings. On the left here, this is a 9-week ultrasound, and you can see here the delineation of the amniotic membrane. You can see that the upper part of the fetal cavity is within this amniotic membrane, and then the lower part is actually outside of the amniotic membrane. On the right side here, this is a 13-week ultrasound. You can see the spine here. There's severe scoliosis. You can see evisceration of the liver and some of the abdominal wall contents, and this is stuck to the placenta, which is demonstrated here. So the major diagnostic clue for a body stalk anomaly is an abnormal appearing fetus that is fixed to the placenta. So this is a 16-week ultrasound, again showing the severe scoliosis. You can see that this is the lower extremity, upper, and then this is the head. The babies typically are not positioned like this. And you can see that there's a defect here, and all the contents are stuck to the placenta. So again, indicating a short or absent cord. And then lastly, I wanted to discuss bladder exstrophy. So this is when the mesenchymal cells fail to migrate between the abdominal ectoderm and the cloaca. Therefore, there's no muscular or connective tissue that covers the anterior abdominal wall. 5 ultrasound findings are described for this prenatal diagnosis. So 1, non-visualization of the bladder. 2, lower abdominal bulge formed by the extrophied bladder. 3, if it's a male, a small penis with the anterior displaced scrotum. 4, a low umbilical insertion. And lastly, widening of the iliac crest. Bladder exstrophy does occur less frequently than cloacal exstrophy, and this I will be discussing in part 2. So on the left is a graphic to help us better visualize this condition. So you can see this is the bladder here that is outside of the abdominal wall. This is the penis, and what they're pointing at here is epispadias. Genital anomalies are also present or may also be present with bladder exstrophy. The umbilical cord is inserted centrally and it is above the defect, but it's typically lower than normal. And on the right is a sagittal view showing this irregular contour here of the lower anterior abdominal wall. The defect is seen below the umbilical cord insertion, and you can't see a bladder here. Bladder exstrophy in this case was confirmed at delivery, and surgical correction is done to prevent an ascending infection, incontinence, and prolapse. So if we see an absent bladder, but normal AFI, this is something that should be on our differential. So bladder exstrophy and genetics. So there's a clear genetic background with chromosome aberrations, but so far there's no consistent finding apart from 22q11 duplications, which is seen in 2 to 3% of these patients. Some genes are implicated, such as those listed here, but most are not explained molecularly. One group performed chromosomal microarray analysis on a cohort of 140 persons born with a bladder exstrophy, and they looked for microscopic chromosomal deletions and duplications. The pathogenic or possibly pathogenic microdeletions or duplications were found in 16, so 11% of those. And microdeletion or duplications with unknown significance was seen in 9 of those patients, so about 6%. A closer analysis suggests that a few gene networks that are involved in the pathogenesis of bladder exstrophy are this WNT signaling pathway, the RIT2, and the POU families. So several ultrasound imaging characteristics allow distinguishing between these defects, and I think that this chart is extremely helpful when you're trying to decide what is the abdominal wall defect. So I'll go over the ones we reviewed today. So here you can see gastroschisis. Is there a covering membrane? No. The site of the defect is to the right of the umbilical insertion, and the umbilical cord insertion is normal. With the body stalk anomaly, remember you have herniated organs and the cord is absent or short, so you'll have the abdominal contents that are stuck to the placenta. And then in bladder exstrophy, the cord insertion is the bladder exstrophy, the anomaly is below the umbilical insertion, and the umbilical cord insertion is lower than normal. So to summarize, prenatal ultrasound has a high sensitivity for abdominal wall defects. The umbilical cord insertion can clue you in to a particular anomaly. And then diagnosis of gastroschisis is associated with higher levels of MSAFP when compared to omphalocele or other neural tube defects. And then it's important to remember, and I learned this early in scans, but there is a physiologic herniation. So when you see a defect, the diagnosis should not be made prior to 12 weeks. And we typically, or you can bring a patient back in a few weeks to evaluate again, just to make sure. All right. So I will do part 2 next month. Thank you.
Thanks, Sonia. Question, and so with the absent umbilical cord, how does it sustain to the point where we can even do an ultrasound to
So remember, it's not absent, it's just not visible, right? Because the fetus is stuck to the placenta. Whatever connection that they have is just so short and so small that we can't see it. Yeah, it's present, just not in the way that we would typically expect it to look. You will definitely see, all of these anomalies at some point in time during your career, and all of them, with the exception of bladder exstrophy, you should be able to make it your NT scan, right? So nobody should leave their NT scan if it's after 12 weeks, with omphalocele, which I know we didn't talk about today, a gastroschisis or a limb body wall complex that is undiagnosed. Like, one of the values of doing an NT scan, and hopefully one day first trimester, anatomies is being able to make these diagnoses early. Bladder exstrophy may be a little bit tougher. I've never made a bladder exstrophy diagnosis at the NT, but I have made all of the others.
A quick question. So in terms of, since, with fallacy before we make that diagnosis because of the physiological changes. So do we use a crown rump length of 45 millimeters or more, or 12 weeks?
I say 12 weeks, but I know that there are differences. And if you're ever worried, you can always bring them back in 1 to 2 weeks and look again.
Just one more question. So the limb body wall, it's like mostly it's idiopathic, that's genetic.
Yes, I would not typically recommend diagnostic genetic testing with a limb body wall defect. They're not spontaneous, not likely to recur, not thought to have a genetic etiology as far as I'm aware.
A couple of quick comments. That was a great review. Sonia, the one issue. Miriam, can you mute your?
I think that's the same thing that was happening.
Can somebody mute Miriam? There we go. Real quick, a couple of controversies. One is gestational age of delivery, and we used to be more aggressive before. Now the trend in the data and the management seems to, wait more till 30, 39 weeks where we'll deliver, anybody else. I don't think there's really any good data, and I think this was covered well into, is there a level of bowel dilation or possible atresia that you need to get the baby out? But you'll see a lot of controversy, a lot of, opinions on that. In the literature meetings. And the other thing is, where to deliver. We used to deliver this all here, gastroschisis. Now there is more a push to deliver where they can put where like a pediatric surgeon could put a silo in. They usually don't need repair an hour or two after delivery, but somebody needs to put a good silo and kind of isolate the bowel and begin to push it in. But if anybody has any other opinions, those are certainly areas of major debate in our field. Any other questions or ideas? Sorry, I came downstairs. I'm having chills and shakes, and I don't want to infect more than I have already. I guess anything to discuss? Well, we're waiting. At 10:30, we're supposed to have Eric Berg give us a fetal therapy follow-up lecture. I don't see him on unless he is under another name. So I guess we'll wait for him to come. Anything else before that?
Hey Vincenzo, this is Joanna Costa from the Morse. How is everyone?
Hello.
That was a really great talk. I always try to listen when I can. And I just wanted to talk to your point about the kind of equivocal data about timing of delivery for babies with gastroschisis. There is a trial going on right now out of the University of Wisconsin called the GOOD study. It's gastroschisis outcomes of delivery. And we are participating in that and trying to enroll patients, but essentially they're looking at randomizing patients who meet inclusion criteria around 32, 33 weeks to either expectant management and delivery at 38 weeks or delivery at 35 weeks. So just something to put out there that is, there's more ongoing.
Joanna, what's the mode of delivery in that study? Is it specified or is it just timing?
It's really just timing of delivery. The mode of delivery is left to kind of other obstetrical indications. It's really just focusing on the timing of delivery. There's pretty strict criteria that I don't have in front of me right now, but just something to think about as you're counseling moms regarding that, and then the option to participate if they're candidates. And then the other thing I wanted to say is there's our surgeons, and I think kind of more people across the board when performing closure of the gastroschisis, the preference is to perform it doing like a sutureless closure rather than taking the baby to the operating room and closing the defect when the bowel's reduced. They actually utilize the umbilical cord as kind of like a natural biologic dressing without having to perform any real surgical procedure. And that's been shown to kind of improve the timing to feeds and things like that. And so that typically is the preference of our surgeons here. So if you do have a delivery for gastroschisis, we always ask that you give us a nice long cord so that we can preserve the option of doing that when appropriate.
And can you expand a little bit on timing? Like, the silo goes in right away, and how do you decide when to operate?
So typically the surgeons will evaluate if not right in the delivery room here, soon after the baby's in the NICU. And if the preference is always try to do a primary closure if that's appropriate, or like if that's possible, right? Sometimes the visceral-abdominal disproportion is such that that's not possible. But if they can, they'll always try to do that first. But if not, then the silo will be placed if not in the delivery room, then shortly after the baby gets to the NICU. And the reductions usually occur, I would say, over like 3 to 5 days. And once the bowel can be reduced entirely, then they'll do that closure.
Great. Eric Berg is having problem signing in, but he's trying to sign in. So I just shared our Zoom link again. Hopefully he'll be able to join us soon. Any other questions? Well, thanks everyone for joining. He should be joining us soon. I guess we can take maybe a tiny break till he comes. Obviously, we'll all stay around. But thanks again, Sonia, for a great lecture.
And you're an ultrasound teacher. Don't blow the surprise. Don't blow the surprise. But also come and tell us.
I don't want to know because I think it'll say. I've only so many times been like.
Do we have more cases to review? Outpatient, we got an new CRITA last week.
Oh, yes, I can show those pictures, Dr. Roman. I'm just gonna log back on.
A very interesting case is going to be the liver
next week.
So I think it's interesting to review.
Yeah. No, that was one that I did want to show. I'm just gonna. She's getting her MRI today.
There you go.
Oh, okay. Dr. Bird joined.
There he is. You're muted, still.
Good morning. I apologize. I was having some real technical difficulties on this side. Can you hear me okay?
Yeah, we can hear and see you. If it's okay with everybody else, I think Harry should take over, and we've been waiting for you. So thank you for giving us this update.
Thank you for waiting for me. I have here a kind of a little bit of a presentation here of some of the patients. So I'll just share this right now. Screen 2.
I was just at EASWOG, and a lot of your friends were there, like Mike Babington says hello, and Raman was there, and of course Eckerville, et cetera, et cetera.
Yeah, it's a bit of a small community.
Yeah,
Each
yeah.
other. So this is like a little bit of a kind of a report that we run. And I was able to pull a report of patients that were coming from Jefferson, kind of center city referrals that I had somehow at some point seen during my time here. And I have a bit of a presentation on one of these patients with some follow-up on Gabriela Anguiano Cruz. I'll come back to her, but just so you may recall, this is a patient that had modi twin pair that was complicated by ectopia cordis in one of the babies. There's another patient, so and I apologize, my first time joining your meeting, so I'm not sure exactly how you run it, but I did want to just kind of pull out some patients we'd seen and give you whatever follow-up I have on them.
This is perfect.
Okay. And let me just close my door. It's possible that maybe I don't have all of the patients you want follow-up on. So if there's someone that's missing, please let me know. There's quite a, we do see some normals, so I took those patients off the list. But Yanis Ramos, so it says she's 61 weeks and 0 days, but that's because she delivered at 36 and 4. Is a patient who was diagnosed with a supraventricular tachycardia second to an atrial flutter during pregnancy. This patient was started on digoxin and flecainide. Because of a history of a classical C-section, we performed a delivery at 36 weeks. It was uncomplicated. And the baby had essentially a normal postnatal echo and a normal course, was followed in the CICU, not started on any medications. Had a pacing study done relatively recently after the baby was born that showed no inducible arrhythmias and is doing well at this time. Another patient that we relatively recently delivered, so Tessia Tarrant. This is a patient who had a diagnosis of transposition of the great arteries in that baby. Delivered with us at 37 weeks and 3 days. Mom had an uncomplicated delivery. Baby had negative microarray during the pregnancy. Got a balloon septostomy on day 1 of life, and then it's not showing it here, but this mark here should say something about how the baby did have a switch operation, which was successful, but subsequently got readmitted with arterial switch operation that was successful. Was subsequently readmitted in August with a sternal wound infection, treated with Keflex, and then recently had an echo, which showed there was some narrowing of the main branch of the pulmonary arteries. And so this baby is going to be going for a repeat cath relatively soon with angioplasty for that narrowing. That kid has had a little bit of a rocky course and is going back to the OR. We have a couple patients that are just still in the queue that we're delivering. So Freylin Diaz Perdomo, she's 33 weeks and 1 day. This is a baby with another TGA that's going to be delivering with us close to 39 weeks. Joy Plotz is another patient we evaluated here 2 days ago who's got a complicated modi twin pregnancy. One of the babies has intrauterine growth restriction as well as a type of tetralogy of Fallot. And mom has a history of kind of hypermobile Ehlers-Danlos and is going to be delivering with us close to 36 weeks as long as both babies continue to be growing. I touched base with Dr. Roman about that patient the other day. If we look at some of the other patients, there's one that we're still not currently evaluated here yet, but this is a patient with hypoplastic left heart, single umbilical artery, intrauterine growth restriction, who's currently 25 weeks and 0 days from your practice, who the plan is to bring her in for evaluation and likely deliver her here. I think there is some history of pseudotumor cerebri, but I think otherwise she'll be a good candidate to deliver here. So she's coming in for evaluation relatively soon. There's 2 patients that we saw that I think both decided not to continue pregnancy. So Veronica Zabo, who's a hypoplastic left heart, as well as Rachel Schleisinger, a tetralogy with pulmonary atresia. This patient had a PPROM after an amnio and underwent a DNE. Sounds like it was uncomplicated. And one other patient, and I'm not sure maybe if anyone on the phone has any additional information, but this is a patient that had a muscular VSD who unfortunately had an IUFD at 34 weeks. I'm not sure if there was any other workup, but delivered, I think, with y'all. And those are really the patients that I have that kind of came through here with major anomalies. I have a presentation about Gabriela Anguiano Cruz.
Can I ask you, Eric, real quick, something interesting? So right there on that slide, so gestational age 58 weeks. We're not used to see that, and I just wanted to know. I guess it's wonderful for an MFM to see that the baby was born and you continue gestational age, from LMP. Can you tell us a little bit more about the background? Is the specialty going, especially in terms of fetal therapy, into kind of using this more often as pediatricians okay?
Not at all. No. This is a templated report I run. So typically patients who populate on this report are currently pregnant, and when they they fall off, when they deliver, they fall off. But I adjusted it so that anyone who ever hit this institution just stays on it. So that's why the gestation age looks so far.
Okay.
But gives you a sense for how long ago this patient delivered, right?
Yeah.
So this is a really, really interesting case, and kind of occurred relatively recently when I started here. And I'll pull up some of the images I have here for this patient.
Dr. Berg, really quick about Gina Krupp. Sorry, this is Sophie. I'm one of the third.
Yeah, sure.
Gina Krupp, the one that kind of fell off the list, she had genetics performed elsewhere, and this baby was also complicated by a portosystemic shunt, FGR, ventriculomegaly, and probably some other minor anomalies that I'm forgetting. But she was identified to have I think it was a micro deletion. I can't remember what it was exactly, but anyway, she was kind of phenotypically normal. The mom was had this same genetic change as the fetus was identified to have, with obviously a more severe presentation in the fetus. So she's actually pursuing IVF for her subsequent pregnancies.
Okay. Yeah. So that's great. That's really helpful, and I think I'd love to collaborate more. Well, this report that you're seeing here, it tells us where patients are either like, this is the patient that delivered with the ADU, with someone that we're kind of evaluating to be determined, patients that have like some other delivery outcome, and then if they delivered a TJU, it populates. We can click here into this link, and it just pulls up their red cap actually. And I can just add in that this patient had any sort of like negative microarray or something like that, and it will populate back onto this the next time we run it. It runs so it's something we do here. It runs every 2 minutes so that any updates. But all that data we have submitted for kind of IRB so that we can look backwards. So this is all being generated off of data that's put into a large REDCap database right now. But I appreciate that follow-up. We'll add some of those parameters in here going forward. I don't know if there's anyone else that I didn't touch upon that you guys had questions about that maybe somehow missed my list. And if not, that's fine.
Eric, Alexa is not on, I don't think right now. Fetal therapy coordinator should be one that I'm sure will be interested in this, and I'll make sure that she's aware. I think she's busy with a procedure right now. Yeah.
No problem. Well, what I'll do is I'll just pull up these slides I have for this one patient here. Let me see if I'm sharing the right slides. Can you guys see my slides are they changing slides right now?
Yes.
GAC?
Yes.
Yeah, okay, great. So there's a patient that was, and does it look okay right now when you guys are looking at it, or does it look funky?
We see your presenter view.
Let's see here. Let me just change this to the different screen. I'll put it onto this one. Does it look better now?
Yes.
Yeah, okay. So this is a patient who's 37 years old, was a para zero, initially referred for a kind of a second opinion evaluation with us at 31 weeks. Noted to have Modi twin gestation. One of the babies had a large abdominal defect, twin A, consistent with likely diagnosis of pentalogy of control. She had had an amniocentesis in both twins, and CMA was reported as normal for twins A and B. I think that's as far as the genetic testing had gone. NIPT had already also resulted low risk, and then she had no other medical OB surgical history, and no real history of any sort of genetic syndromes in the family. This is kind of just a plot of how the growth had gone. So that one baby had been measuring smaller. I think the initial discordance was around 24%, subsequently kind of tightened up a little bit, but still remained a small baby. And this is the anomalous baby. We didn't get an MRI, I think just because of the late timing that we met her. I think she also met you guys late too.
Yeah, she presented at 28 or 29 weeks to us.
Yeah. So I think we didn't really have time to coordinate the MRI necessarily, nor did it change what her desire was, which is, just to do everything she could for these babies. And I think, in fact, with large umbilical, late MRI is less, there's some data that late MRI is not nearly as good as an early MRI. But we tried to just kind of use 3D ultrasound to assess pulmonary volumes. And then what you can see here is just the total pulmonary volume that we could kind of predict based off 3D volumes in the little one. And clearly there's a huge margin of error because of the error associated with ultrasound. But the basic gestalt here is that baby had smaller lungs, but nothing that we could really say about whether or not the kid would breathe or not breathe. There's some different measures of how you evaluate a giant omphalocele. This is it's called the OC-AC ratio. Anything that what you can see here is you can use this ratio and to kind of look at it to determine whether or not a baby falls into a really bad category, and from basically like a survival percentage. It's really not based on a lot of data. But there's a nice publication where they kind of looked at this ratio and then looked at gestational age and the ratio size to determine, survivability. What you can notice is a lot of people in this cohort had terminated the pregnancy, but of the people that did not terminate, here are alive and well. I think the basic message here is that the further you go in the pregnancy, the more likely you're to have a child that's going to be alive and well. And certainly the lower the ratio, more likely to be alive and well. But what I think is also interesting is that there's IUFDs both above and below this line, and I've drawn this line where our patient was, right? So she was delivered around 33 weeks with a ratio of 0.67. And so there was really nothing we could say 100% that this baby was at continued risk or was safe to continue following. But certainly with a Modi pregnancy and an anomalous twin that's growth restricted, there's a low threshold to proceed with delivery if there's anything that looks like it's going wrong, particularly in the setting where you could have spontaneous IFD, above and below this gestational age. So here's just a sweep. I'm sure anyone familiar with the case remembers this is a baby who there was a small diaphragmatic defect as well as a large omphalocele, and you can see the tip of the heart was pointing out here, extending beyond the sternum. Postnatally, and I think prenatally, there was both concern for perimembranous VSD, but otherwise the structure of the heart was pretty normal. So at 32 weeks and 4 days, we got a call because there had been some concern that there was some spontaneous bradycardia in that anomalous twin. And so she was initially stabilized and monitored at Jefferson, and then was transferred back to Nemours with a plan for delivery after a steroid course. And so mom got a course of steroids, and then we delivered basically at this should be 32 and 6, so almost 33 weeks. She had a fan and steel. We did do a classical just so that we wouldn't have any difficulty delivering the large giant omphalocele without any trauma, and as well as because she had opted for a bilateral self-injectomy at the same time. So twin A, the affected was 1,890 grams at birth, APGARs of 3 and 5, was intubated and given surfactant. This is what that baby looked like at birth. So you see a large excuse me, abdominal wall defect above the umbilicus, as well as a parasternal defect with herniation of the heart just underneath the skin flap. And then what you can notice as well in this picture, there's some edema around the neck of this baby, which was not significant at birth, but did become a problem for this baby going forward. So a CTA of the chest was consistent with pulmonary hypoplasia, chronic lung disease, and hyperinflation, and the baby needed to remain intubated on ventilatory support. Echo showed a perimembranous VSD, otherwise essentially normal. Um, I'll just skip that part. The same twin did eventually have some wound breakdown just because of how distended the skin was on the abdomen. So pediatric surgery really only remained involved from a standpoint of debriding some of that breakdown, and I'll show you some of this, and monitoring the healing process. So here's what that initial looked like at day, like kind of first couple days of life. You see the defect is above the umbilicus, and then here's where it did have a kind of a wound breakdown. This had to be debrided and then just healed spontaneously over time. Baby remained intubated. They did aggressive pulmonary toilet. We're not able to extubate this baby, and we're hoping that they would be able to place a tracheostomy, but ultimately the baby developed a lot of swelling in the neck. Beyond what we saw at the initial first picture I shared. They performed an MR, which showed that there was evidence of microcystic lymphatic malformation in this baby. Baby was started on sirolimus, which is an mTOR inhibitor, commonly used to treat lymphatic disorders, and there was no real improvement despite therapeutic levels. And so what you can see, this initial swelling just became very, very pronounced under the baby's chin here. And so they're unable to safely place a tracheostomy. And ultimately, baby remained intubated, and because of the inability to extubate with no real clear path in sight towards leaving the hospital, the family elected for a compassionate extubation at 94 days of life. Twin B was unaffected, had an uncomplicated NICU course, was discharged home after 8 weeks, is currently doing well, meeting all milestones at 5 months. Normal exam with the exception of right-sided periauricular skin tags ×2. So you can see these skin tags here, but otherwise no other issues. And then a whole exome sequencing was performed in the postnatal period. And interestingly, both twins carry a single heterozygous mutation in the CDC42BPB gene. And this is extremely rare mutation. It's de novo because they didn't find it in the parents. And for the lab, characterized as likely pathogenic. So this gene essentially creates some proteins that regulate another gene called CDC42, which, if that's abnormal, can lead to a syndrome called Takanuchi-Kosaki, which is essentially can be associated quite a few different problems, some of which showed up in that the affected twin, including there's a lymphedema, so that's one of the major issues, as well as cardiac issues. I'm not sure it necessarily explains the pentalogy of Contrail, and there's really very few cases reported of this. But the actual problem in this gene, the CDC42BPB gene, is characterized as something called Chilton-Okerger-Chung syndrome, of which there's only 14 cases that we could find reported in the literature. And most of those kids are associated, or at least people that are living with that, have some associated developmental delays and intellectual disability, which is not necessarily 100% assessed in a twin in the healthy twin at 5 months. So that's something they're just continuing to look at and watch for. But this is a case which I know that Dr. Al-Khawadli and I were hoping to write up, and I'll be talking to her more about this case going forward. So,
Erin, can I ask a question about sort of the postnatal compassionate extubation, if you will, of twin A? And maybe this is a better question for like a neonatology person, but what what are the ethics of that, and when is that offered, and how does that work legally? Like, I just have a lot of, I'm not suggesting that it was the wrong thing. It sounds like this was the right thing to do for that baby. I just am wondering, how does that work? And sorry, it's Whitney Bender, one of the MFM attendings.
Oh, it's nice to, thanks for your question. You know, I think actually, I think Joanna Costa's on this phone call and she
Who's
probably
actually,
has.
so I'm Justine. I'm one of the third year NICU fellows. I was
Oh,
at
Justine.
Moore's during this whole
Oh, great.
discussion with these parents. So it was a lot of back and forth. It was like 3 to 4 weeks of discussion with surgery, with cardiac surgery, with kind of where we can get this baby to surgery to get the ectopic cordis fixed, because the parents did not want to compassionately extubate. The problem was we would need to keep the baby alive for at least 18 months to get to cardiac surgery and umbilical repair. And we did not think that the baby could survive 18 months without a trach. And she was having these kind of really big apnea, Brady DSAT events that were looking like it was a really difficult situation. Like, we were not DNR. We would have to resuscitate heart would be really difficult, like CPR. So we were trying to discuss how we would even do CPR with an ectopic cordis. So based off of all those discussions, we had a lot of CT cert. It was like we would have to go above, because I think it was her right ventricle that was like most displaced out.
Yes.
So we couldn't like just do that, pump it. So based off of all of that, and it really was a tracheostomy that was this lymphatic malformation that was likely not even related to
The major defect.
major defect. So yes, it was a lot of back and forth. It was a very, very difficult decision for the parents. And that was kind of the formal decision.
So tragic.
Yeah, palliative.
Yeah, I can chime in a little bit too. To echo what Justine said, this baby was going to live in the hospital for months and months and months without the ability to, with a tracheostomy, at least there's other things that you could do developmentally and things like that. But with the lymphatic malformation and just all the other things happening around the neck and the chest, that just wasn't feasible. And she had already had a number of complications. And that just was, I think the parents were also worried in the end about the potential neurodevelopmental outcomes, not just from how sick the baby was and the prolonged hospitalization and the critical illness, but also this genetic difference that was identified, and ultimately did not wish this or did not accept this as a quality of life for her. And so we met with them, we met with the team, and really felt that it was, permissible for them to make this decision.
I have a quick general question for Eric. Exome and genome, sequences becoming, more and more done, not only available, but, done more and more frequently. Wonder if you could comment on your approach, in Texas as now there on the Moors. Again, coming back from ISWAG, it sounds like, we should get an exome genome on any anomaly at this point. And the yield seems to be, really interesting. And as you can get some, changes of unknown significance, as you know, but obviously this may not be the ones you found. So I wonder if you could expand on what you guys are doing in the Moors. Both, I guess, and also the pediatricians they do it even more in babies, I know.
Yeah, thanks for the question. It's interesting that you ask. We have just hired some additional genetic counselors for our program. 3 new counselors, one of which is starting in about 2 weeks. So I can tell you that prenatally, what do we do at Nemours? We've not done traditionally much here prenatally. But I myself, in my own experience in my past institution, and I think going forward here, we often, some of the decision making, I think, revolves around what, certainly there's like a financial component to it, what is covered. and what a patient's willing to potentially pay. So a lot of, I agree, it actually makes sense to go more towards next gen sequencing for many things, particularly high drops. But a lot of times we start with a CMA with a reflex to that if it doesn't come back. But I would say in my experience that particularly with high drops and anything that's not very straightforward, we just move right to next gen sequencing. I wish I could have attended ISWAG. I'm sure it was a very interesting conference. I have, I'd be happy to talk more to you after we kind of establish more of our own program here in the next month or two. But that would be my recommendation to most patients is that if you can move forward with next gen sequencing, it's just given the time constraints, it makes sense to start as early as possible. But I think for, at least in my last experience, many patients for whom it wasn't covered necessarily or was financially, a huge burden, they would just proceed with CMA.
Hi, Dr. Berg. This is Stephanie Rice, one of the genetic counselors with MFM, and I really appreciate you and all that you guys are doing. This is wonderful for our patients. And I would say also too that Andrea was our contact, Shellhouse was our contact before. And if they're once you guys are up and established with your genetics team, would love to have that connection as well, just to ensure continuity of care. Specifically like with Joy Plotz, she's a perfect patient that I'm thinking of that would need additional genetic testing. She had opted for the route of just doing a Noonan panel mainly due to her financial constraints and unfortunately denial of coverage usually with exome and genome sequencing in pregnancy. So love to talk to you more off air about that. That would be great.
Yeah, absolutely. We were part of a study in Houston that we were able to get a lot of patients next gen sequencing that was covered by kind of research. But outside of that, most of our patients really couldn't afford if it wasn't covered by their insurance. We're happy to connect you with our new colleagues who'll be arriving within about a week or two.
Wonderful. Thank you.
Mhm.
I mean, thank you, Eric, for spending time with us. If there are any questions, we'll let you go, but we hope to do this, more
Absolutely.
frequently as we can. Again, it'd be good for Alexa on our side to see that list of things you have, make sure it's complete and stuff. And let's keep the communications going. Congrats on your program.
Thank you. Yeah. What's Alexa's
growing.
last name, Vince? Sorry, I interrupted you.
No, go ahead.
Alexa's last name, if you wouldn't mind just telling me.
Herman,
Oh, Herman. Okay.
Herman. Yeah.
Okay, great.
I'm sure she'll be interested in seeing that, and she always has extra things to add and stuff.
Okay, great. Yeah, happy to talk more.
Yeah. Good to see you.
Good to see you all. Thank you so much for inviting me. Talk
Thanks.
soon.
Thanks a
Okay.
lot.
Bye.
And thanks, Joanne, as well. Thanks, everyone.
Bye.
I guess in terms of us in MFM, again, I'm going to stay downstairs not to infect anyone. We were going to go over, the last thing is to go over the outpatient list.
Yes, I can.
Is that what your plan was?
I think so.
Yeah.
Go ahead.
Share my screen.
I'm going to, mute myself.
Okay, so our first patient is Armani. She is our 23-year-old G4P0030 at 30 and 6 today. She's on our continuity list for thickened nuchal fold and early onset ICP. She has downtrended bile acids, most recently 0.2, and downtrended LFTs. She also had the concern for EBV in this pregnancy. I reached out to Dr. Dutra, and she thinks she had reactivation of EBV. It's unusual for EBV to cause cholestasis, but it has been reported in the literature. So she thinks this clinical case aligns with kind of like resolving EBV infection. We'll chat more about it tomorrow at Plus Clinic. We are kind of following her for surveillance with serial growth ultrasounds. Her next growth is on 10/1. She's getting weekly NSTs at 28 weeks, which are scheduled. And then our division meeting last week, we kind of agreed that we plan to deliver her after 36 weeks, so between 36 and 39 weeks. Our next patient is Denise. She is our 33-year-old G4P0120 at 11 weeks and 4 days. She's on our continuity list for type 2 diabetes, ACTH-dependent Cushing syndrome, chronic hypertension, obesity, and a history of IUFD at 20 weeks. For her diabetes, she is poorly controlled. She had her recent up titration this week. She's on Lantus 60 units and Humalog 20 with all meals. The last time we saw her on 9/16, time in range was 13%. And we'll continue to try to optimize her sugars. In relation to her Cushing syndrome, she had her initial surgery in 2018, had a recurrence with surgery most recently in June, currently has adrenal insufficiency, which endocrinology believes will persist for at least 6 months after her surgery. So she's on prednisone, which is planned to be continued throughout the pregnancy. So she'll need stress dose steroids if has an illness or for delivery. She continues to follow with endo and ENT. For her chronic hypertension, her blood pressures are well controlled and she's had normal baseline preeclampsia labs. She also had an abnormal echo in kind of baseline workup for her chronic hypertension. She had a hyperdynamic heart with an EF of 70 to 75%, normal systolic function, and this moderate dynamic obstruction with Valsalva. We saw her at Cardio B Clinic, and there's no findings to suggest hypertrophic cardiomyopathy. And the plan is to kind of maintain hydration to not provoke this obstruction, avoid diuretics and volume depletion. We ordered a BNP pending completion, and then we're going to repeat an echo in the 3rd trimester to kind of assess that gradient again prior to delivery. For the IUFD, her APLS labs are negative. Unclear etiology as to the demise of this baby.
For this patient who is poorly controlled diabetic, I'm following her every day. I'm calling her daily to watch her diet and insulin, and she's doing much better with the last adjustments we made it. And she's booked for weekly evaluations with Diabetic Clinic, and she prefers to come in person to do heartbeats, ultrasound, because she's anxious about demise. So that's the plan, and so far she's happy with her plan. I called her last night, and she's okay.
Thank you, Dr. Roman. Our next patient is Miss Shafla. She is our 26-year-old G2P1000122 and 1 with a monodiaphragm pregnancy with demise of twin B at 16 weeks. Last time we talked, we discussed the MRI, which our lovely Alexa has kind of helped coordinate. She has her new insurance and received authorization. So Alexa was going to fax over those to CHOP for fetal MRI of the brain and the body. She is scheduled for a growth ultrasound every 4 weeks. Her next scan is on 9/29. She had a fetal echo scheduled. It had to be rescheduled to 9/22, and we'll start doing weekly NSTs starting 32 weeks. No indication for delivery prior to 39 weeks if she remains uncomplicated. Our next patient, Sierra Colon, She is a 24-year-old G1P0, 25 and 0 today. She's on our continuity list for hypoplastic syndrome that was diagnosed on fetal echo on 8/20. She saw peds cardiology for a consult on 8/27, and the diagnosis was confirmed, in addition to having an aortic and mitral atresia. She has a follow-up peds cardiology echo next week with Dr. Shrivastava. And she has already met with Dr. Alquatli and the genetics team for an amnio and genetic consultation. Microarray is negative. Her amniotic fluid AFP is also negative. From the last note, she was trying to do prior authorization for exome. The plan is for delivery at Nemours. However, timing is pending because this baby has severe FGR with EFW less than the first percentile, single umbilical artery, and a filamentous cord insertion. So timing of delivery will depend on kind of fetal status. Our surveillance plan right now is weekly UAD Dopplers, growth every 4 weeks, and twice weekly NST starting at 28 weeks. For maternal history, she does have this history of idiopathic intracranial hypertension that is managed with a Diamox 125 milligrams daily. She's overall stable on this dose. She has a neurology appointment on 11/3, so we'll see what they recommend.
Just wanted to update that, unfortunately, the authorization for the exome was denied, but we are in the process of doing peer-to-peer with Keystone. It was denied for a silly reason because it was going to be performed out of network. And as this is, of course, a highly specialized lab test that I think we have a good case of possibly having it overturned, as we did for a very similar case about a year ago. So stay tuned on that.
Thank you for that update, Stephanie. Our next patient is Miss Jessica Green. She's a 34-year-old G3P0020 at 30 and 0. She is on our continuity list due to her history of proteinuria starting at 12 weeks. We finally have a diagnosis of Alport syndrome, which is X-linked. This proteinuria started in pregnancy. She's had a normal renal ultrasound, and nephro has been following her, which is where she got the Natera Renocyte test that showed Alport syndrome. I reached out to her nephrologist, and overall the plan for her is to slow the progression of her disease so that she's able to keep her native kidneys for as long as possible. She sees Dr. Shurkin, and they recommended, because I'm not sure better, but they recommended audiology and ocular eval. So I'll ensure that she has those referrals in place, and then she's going to be followed by nephro monthly for labs and urine protein count. And then postpartum, the plan is to use antiproteinuric medications such as ACE inhibitors or ARBs, coupled with SGLT2 inhibitors, to try to slow down again the progression of the proteinuria. On these medications, she cannot breastfeed. The patient is okay with not breastfeeding. So that is the plan once she's delivered. And then her next appointment with nephrology is on 9/30. Overall, she doesn't have a lot of significant medical comorbidities.
We're also in the process of trying to get her scheduled with genetic counseling. From my understanding, fetus is male by NIPT, so there certainly is an increased risk of Alport in the fetus with more severe disease given it's male. So stay tuned with that as well.
Thank you. Our next patient is Miss Heyman. She's a 37-year-old G8P1516 at 26 and 5. She's on our continuity list for monodipe pregnancy that was spontaneously conceived. We're following her for TTS screens Q2 weeks, serial growth ultrasound Q4 weeks, and NST starting at 32 weeks. This is the patient that desires a Lotus birth. She saw Carrie this week, but it seems like a lot was going on. So the plan is to discuss that we can do a Lotus birth for baby B at the next visit. She does have preterm deliveries, so she's on vaginal progesterone. She has a history of asthma that is not well controlled. She presented to triage for loss of consciousness, and Sophie increased her Symbicort on 9/14, and then sent a message to the RN pool to coordinate pulmonary referral. As of yesterday, she did not have any pulmonary appointments, so I'll just continue to monitor.
Hi, I'm gonna call today, Pulm and Heme, to get her in sooner with Heme.
Thank you.
You're welcome.
I added Montelukast for her as well.
Oh, okay, perfect. Thanks. She also has a low-lying placenta that appeared to resolve on a bedside ultrasound that Dr. Roman and I did to do a check because she missed one of her TTTS appointments. But we're awaiting a formal third trimester ultrasound with the department. She is definitely the left ear, but can hear from normal conversation. And she also has a history of iron deficiency anemia with a hemoglobin of 8.9. The loss of consciousness when she presented to triage had a normal cardiovascular workup, suspected to be as a result of her anemia. So she does have a heme appointment on 10/6, but Melissa said she's trying to get her in sooner. Our next patient is Miss Lee. This is a 30-year-old G1P0, 20 and 1 on the MFM continuity list for a history of subarachnoid hemorrhage secondary to a 1.3 millimeter subclinoid ICA aneurysm back in 2022. She's had a normal angiogram February 2025 and is following with neurosurgery. They did recommend cesarean delivery, avoiding spikes in blood pressures. Her blood pressures have been well controlled, and they do not seem opposed to neuraxial anesthesia. However, we're going to plan on a third trimester anesthesia consult to make sure that everyone is okay with that plan. After she delivers, neurosurgery is planning to obtain an MRA just to reconfirm that she remains aneurysm free. For her antenatal surveillance, she's already had her anatomy and overall is uncomplicated. So there's no indication for NST's delivery indicated after 39 weeks. And she's following with the generalist group as of now. And we'll see her again in the third trimester to try to coordinate her delivery care and plans. Our next patient is Tonisha. She is, she is a 40-year-old G11P5055, 27 and 4. She's on our continuity list for chronic hypertension managed with medications and non-ischemic cardiomyopathy in the setting of like hypertensive urgency. For her chronic hypertension, she's on GDMT with Coreg 25 BID and Hydrel 50 TID. She's also on aspirin for preeclampsia risk reduction. Previously, her Hydrel was up titrated to 75, but she did not tolerate it. She's had normal baseline health labs in this pregnancy. We saw her in cardio B on 9/16, reviewed her blood pressure logs. Her pressures at home were normotensive. However, she had some severe range blood pressures in the office. So questionable white coat syndrome. We recommended evaluation inpatient. However, patient declined, requested outpatient labs as of yesterday and this morning. Those labs are still in process, so not available for review. I'll check after the meeting to see if they have resulted and then make sure there's no abnormalities. As it relates to her cardiomyopathy, her most recent EF is 40 to 45%. She's getting monthly BNPs and they have been less than 100. She's gonna see us again on 10/21 for cardio B, and her ROB is on 9/23. And then the plan is to repeat her echo in the third trimester. Her next BNP is due on 9/27. Our next patient is Miss Mason. This is a 30-year-old G8P4034 at 17 and 3. She's on the continuity list for our dichorionic triamniotic triplet IUP. A and B are the monodi pair. She was counseled extensively and desires continuation of the pregnancy. Most recent growth ultrasound on 9/11 showed 5GR in babies A and C, with increased PI and intermittently absent Dopplers for baby A. Baby has normal UADs. She has another TTTS screening on 9/18, which is today. So all those results. Baby B also has a single umbilical artery. However, she declined genetic counseling and diagnostic testing. So the plan right now is to do TTTS screening between 16 and 32 weeks, anatomy, ultrasound, fetal echo, growth Q4 weeks, NSTs weekly, delivery pending fetal status. Our next patient is Miss McMurrin. She is a 33-year-old G7P4024 at 31 and 6 on the continuity list for a history of P in this pregnancy on therapeutic anticoagulation with Lovenox 90 BID. This PE was diagnosed at 11 weeks. She's had a start of the thrombophilia workup that shows negative antiphospholipid antibodies. Factor V Leiden, prothrombin, antithrombin was mildly low, likely due to active clot burden. So the plan is to repeat antithrombin and protein C and S after she delivers. The plan is to keep her on heparin. There was some discussion, keep her on Lovenox, sorry. There was some discussion on transitioning to heparin, but that is not the case. She does have some antepartum anemia with a hemoglobin of 9.8. Iron studies and a workup is ordered pending completion. We encourage her to get those done and we'll treat as needed. Our surveillance plan right now is growth ultrasounds, serial growth starting at 28 weeks. The most recent EFW was in the 17th percentile on 9/10, weekly NSTs at 36 weeks, and no indication for delivery prior to 39 weeks, and no contraindication to vaginal delivery at this time. Our next patient is Gabriella. This is a 33-year-old G1P0 at 34 and 5 on the continuity list for type 2 diabetes. Sorry. For type 2 diabetes, she also has LGA current regimen as of 9/16. She's on Lantus 38 in the morning, 42 at night with 48 of hemalog with all meals. Her most recent growth on 9/2 shows EFW 89th percentile, AC in the 98th percentile. She'll be following up with us for ROB on 9/23. Her next growth is on 9/30, and we are doing twice weekly NSTs. She does have an induction that is scheduled at 37 weeks, and that will be on 10/4. As it relates to her chronic hypertension, her blood pressure seemed to be well controlled with low 500 BID. She does have findings of left ventricular hypertrophy on her echo, and was seen in cardio B clinic this week. And Dr. Jones recommended a dose of Lasix 20 after the placenta is delivered because she's like at higher risk for postpartum heart failure. And the plan is to obtain a NP when she presents for her induction. Our next patient is Ms. Jasmine Palmer. She's our 22-year-old G5P1122 at 24 and 2. She's on our list for poorly controlled type 1 diabetes with LGA. Has had admissions for DKA in this pregnancy. She's had an early anatomy that showed no gross abnormalities, a formal detailed anatomy without any abnormalities, however, LGA. She was seen last at diabetes clinic on 9/9, and did not really have glucose logs essentially. So her insulin has not been adjusted. She's gonna see us again next week, and then her next growth ultrasound will be at 28 weeks. She does have a normal fetal echo. Delivery planning pending her sugars and fetal status. Our next patient is Melissa Richards. This is a 41-year-old G4P0030 at 19 and 5 on the MFM continuity list for Wolff Parkinson White syndrome and SVT. She has had in the past, outside of this pregnancy, ablations, follows with pen cardiology. Her last electrophysiology study in February did not show any inducible SVT. She does have a loop recorder in place to correlate symptoms if she experiences any. She was seen at Cardio-B on 8/19 and was stable. However, if she does present in SVT, it's okay to treat her per ACLS protocol. Dr. Jones's note at the time said if her SVT increases in frequency, the plan would be to start either flecainide or sotalol. She'll be seen by us in Cardio-B on 10/21, and then she has a pen cardiology appointment on 11/19. She also has chronic hypertension that is well controlled. She has normal pre-E labs in this pregnancy, normal BNP, and then her 24-hour urine protein was not at the threshold for pregnancy, despite her PC being elevated. Her anatomy is scheduled on 9/24. Our next patient is Fermina. So she is postpartum day 9 from an SVD and bilateral tubal ligation. She was on our list for familial hypertriglyceridemia and history of pancreatitis. She is still on the fenofibrate and the omega-3. She saw Dr. Watari on 9/11, and the plan is to continue that regimen, follow up in 4 months. Dr. Watari coordinated cardiology evaluation. She does have an appointment on 9/25 to discuss genetic testing for hypertriglyceridemia, since she hasn't formally been tested, and then to evaluate for novel treatments for the disease. She would also need, when we see her for a postpartum appointment, a general surgery referral, because during her antepartum course, there was discussion on postpartum cholecystectomy for her history of gallstones. She also is a GDMA1 and needs a 2-hour GTT. So hopefully we can continue to watch her progress well and try to coordinate her gen surge follow-up.
What does she have scheduled right now?
She doesn't have anything scheduled. I sent a message to get her scheduled for a 3-week postpartum visit with us. So I'll make sure that is done by the end of the week.
How was she discharged without any follow-up?
I'm not sure.
She has a follow-up on the 29th. Is that not? Well, that was.
It wasn't there before. I think I messaged for that.
We messaged for all of her follow-ups after. Her endo, it wasn't scheduled for endo?
No, for us.
Okay.
I'm glad she's scheduled.
She was discharged with Sonia, I guess, right? And
Yes.
on the 8th.
Yes, and we messaged for her follow-up appointment.
Who did you message? At Schedustration or nursing?
I believe Schedustration. We can go back in our staff messages and look.
Okay, and then does she has endo follow-up, but you're saying GI is what needs to be referred?
General surgery, because GI during the pregnancy, they kind of suggested that she might need a cholecystectomy because she does have gallstones, and that could potentially trigger things with her history of pancreatitis.
Melissa, are you hearing? Do you think you can help coordinate with that?
Hi, I'm here. What do you need help with? Sorry, I'm here, but doing a few different tasks.
Yeah, I think we can, Lashayka sent a message about just general surgery coordination.
Sure.
Thank you.
Mm-hmm.
Our next patient is Miss Roberts. This is a 34-year-old G13P7057 at 27 and 4 on the continuity list for poorly controlled type 2 diabetes. Does have polyhydramnios on a bedside ultrasound that Carrie did on 9/9. Her current regimen is 75 of Lantus U500 in the morning and 40 units at night. I will call this patient today because she missed her. Yeah, she missed her appointments and she's rescheduled and she's missed prior echoes on like 9, 10, and 8/13. So just to make sure we get her to come to those visits. And then she had, well, the fetal echo is because of her history of child with cardiac defect. Our next patient is Miss Ram. She is a G1024 and 6 on the MFM consult list for monodi twins with abnormal UADs of twin A. She has had a normal anatomy, normal NIPT, normal fetal echo, ROB scheduled on 9/29. As of most recent ultrasounds for Dopplers on 9/8, 9/11, and 9/15, she's had increased UADs of twin A without any evidence of hydrops. TTTS, selective FGR, are TAPS. She did have a consult at CHOP previously. No need to follow up there unless they're doing a procedure. There's no growth discordance on her last ultrasound, and right now the plan is to do growth ultrasounds 2 weeks, which was recommended by CHOP with us. TTTS screening at least twice weekly, and to be determined when we'll start doing like NSTs, admission to the hospital, delivery timing. I think right now we're doing outpatient surveillance with bi-weekly ultrasounds and 2-week growth scans. Any comments, questions about her?
No, I mean, just with her, it's just important to realize that things will fluctuate, which is not like the traditional course when you're thinking about selective fetal growth restriction and placental insufficiency. She had like absent last week, and then increased this week. So it's just it can be a bit challenging. We just all need to be aware that obviously things can change at any time, and she's been counseled extensively.
For some reason, I thought we had talked about spacing out her ultrasounds to once a week, but maybe something's changed since then.
Yeah, we talked about it, and I think Rupsha and when we said at last meeting, it would be more beneficial to continue rather than fluctuate, go from once a week, then twice a week if needed, and she would benefit from just having consistent surveillance.
She has an appointment later today.
Okay.
Our next patient is Miss Aisha Samuel. So this is a 34-year-old G8P6016 at 37 and 2. She's on the continuity list for a history of SVT. Second degree type 2 AV block with a dual chamber pacemaker in place as of 8/8. She had an echo at that time that showed EF of 60%, was following with Einstein cardiology, was supposed to follow up with us at Cardio B clinic, however missed her appointment. So we were able to get a hold of her pacemaker integrity information from last full BCC meeting. And Dr. Jones reviewed it, and she does not need telemetry. The things that are left to do that I will follow up on is to notify anesthesia of her pacemaker settings, because I know that was a question last week. Meeting. She's scheduled with us for ROB and growth on 9/9. Otherwise, it's complicated. She has an induction scheduled on 10/2. Our next patient is missing. She's a 33-year-old G1P0 at 17 and old. She's on the continuity list for scleroderma with restrictive lung disease. She does not have any renal manifestations of her disease and has had a normal in 2024 and in this pregnancy with an EF of 60%. She follows with pulmonology, had normal pulmonary function tests. However, it did show some moderate restrictive deficit and some gas transfer deficits. We reached out to her pulmonologist to see if there's any contraindications to Valsalva, and her pulmonologist is going to discuss with her colleagues to come up with a consensus. The patient has an appointment with them in January, so we'll have an answer then on Valsalva or not. She is also following with us for weekly echoes because of her positive SSAs. Her last echo, she had a normal PR, and her next echo is on the 19th, which is tomorrow. Our next patient is Miss Torres. She is a 29-year-old G6P0141 at 24 and 0 on our continuity list for poorly controlled type 2 diabetes. She was seen in diabetes clinic on 9/9, previously recommended to be on Lantus 50 a.m., 50 p.m. However, her current regimen is 32 BID with Lispro 40 with all meals. We will see her again on 9/26 and review the blood sugar logs and titrate insulin as needed. She has had a normal anatomy ultrasound, normal fetal echo. She also has chronic hypertension controlled without medications, has had a normal chronic hypertension like baseline workup. And there was concern at 16 weeks for concern for ectopic cordis, but like I said, her fetal echo is normal.
Yeah, I think that could be even removed, right, from the I mean, we've had multiple subsequent ultrasounds. I wonder if we should just kind of.
Yeah, I can remove it.
I mean, I don't know. You guys can decide, but it's just something I was thinking about. We just did her echo with Kavisha last week.
And then our last patient is Miss Watson. She's our 38-year-old G2P1001 at 27 and 3 on our continuity list for chronic hypertension, obesity, history of PE, and subarachnoid hemorrhage, prothrombin gene mutation, and currently on therapeutic Lovenox of 150 BID. Has seen JATs in this pregnancy. Plan is to continue Lovenox and then switch to apixaban postpartum and when not breastfeeding. For this history of CV, it was in the setting of her VTE. She has no sequela and does not want to follow with neurology, so we do not bring it up at appointments. She also had this history of cardiomyopathy, like non-compaction cardiomyopathy. She does not have this disease. Her most recent echo was normal, and that was reviewed by Dr. Jones. So no additional cardiac interventions are needed. She also has chronic hypertension, managed without medications with normal pre-E labs. The most recent things for her is she complained of this left lower quadrant mass. We ordered a Doppler ultrasound, scheduled it, but she did not show up to her appointment yesterday. So I'm going to call her today to see what happened. And then she has this mastalgia with a normal breast exam. We ordered some bilateral breast ultrasounds for her. And that is all I have.
She didn't show?
Didn't show up.
Jesus.
Her office people? Her Doppler ultrasound. Oh.
I wonder also if, again, like Whitney has a relationship with her and, maybe she can help with speaking with her, again, regarding consistency and maybe, I'm not sure. I'm trying to think of what's best because she's someone who really is worried about her health, but then sometimes, doesn't necessarily stay on top of things. The suspicion was low, though, I guess. Anything else to review?
Dr. Roman, are you on?
Yes.
Do you need to show pictures of the accreta?
Yes. Which one? The one done or the one that is?
No, the one for next week.
Okay, I'm ready.
Okay, I'm gonna just pull up her imaging.
Well, you're getting them, so the accreta lady transfer from Avington is stable. They did the percutaneous nephrostomies yesterday. They're waiting for them to be sure that they're working before removing the suprapubic catheter. She looks like she's having again a wound infection. She grew MRSA last time, so I'm afraid they need to open the wound again. Otherwise, she's stable.
I'm gonna bring up the imaging, but essentially this is a 42-year-old who had a irregular menstrual cycles, did not know she was pregnant, found out she was pregnant, presented to PWC at around 14, 15 weeks. They had done a bedside ultrasound and had concerns for a placenta previa. She had, I think, shown up twice to PWC for this attempted termination procedure. With the last ultrasound, they were concerned for possible accreta. The patient does have a history of 2 prior C-sections.
Did they suspect accreta?
They did. I spoke to Dr. Vanaker about it, and they had actually suspected an accreta or were concerned. They wanted to make sure that it was ruled out, given her 2 prior C-sections and anterior placenta. So they sent her over to our unit on Friday to have that assessed. She was 16 weeks and 6 days by our ultrasound. I'm going to share the images. Here, I'm going to start off with these images right here, just the initial one. Here we're able to see, this is a transvaginal ultrasound, cervix is right here, bladder is above, and you can see that the placenta is clearly covering the cervix, internal ostium region. I'm going to skip to the videos that we had initially seen that was an area of concern. So right here again, just looking at our landmarks, we have placenta, bladder, and then this is where the fetus is. We can see next one, there's hypervascularity right by the area underneath or inferior to the bladder. This is one of the first clips that we're seeing. And there is not much demarcation between the bladder wall and the placenta.
So patient already seen by Dr. Kelly, and because of the placenta sitting on the trigon, the bladder look to have good muscularis and mucosa area, but still could be invading into the bladder. So she's going to have urology consult and stents prior to the surgery.
And then there's an area right here that's also, we're not seeing the interface between the placenta and the myometrium that's concerning near the cervix. As you can see in the study, but that's also a concern.
Yeah, here, this area of the cervix is concerning, so I hope they can do a total hysterectomy.
So we're just gonna keep going. Here's someone vessel. You can see there's
Yeah,
a
look, see, oh, this area.
vascularity.
Horrible.
Yeah, right here.
Yeah.
And we see hypervascularity. And also to show this foot right here, again, we're seeing it's really difficult to distinguish between placenta and nutrient. So essentially we diagnosed her with a placenta accreta. She then referred her to GYN oncology. She again desires termination of pregnancy, so this will just be a hysterectomy. She'll be having a midline vertical skin incision. Neurology will be involved from the get-go, given concerns for bladder involvement. And the plan hopefully will be a total hysterectomy. In other words, like removing the cervix. We don't want to keep it as a super cervical, given what we're seeing in our last case. This was all communicated to the oncology team, and the patient is scheduled to present, I believe, on the 23rd for UAE, followed by the next day with the planned hysterectomy with the GYN and GYN. Anything else to add, Dr. Rowan?
No, the plan is, you mentioned she's going to be admitted to MFM next week, I think,
Yes.
Monday, in preparation for consultations and uterine artery embolization the following day, and then hysterectomy on Wednesday. Just anecdotally, I had a case before where the patient was a desired pregnancy, and the patient asked when the baby was going to die. So I mentioned during the uterine artery embolization, and the patient told Dr. Gonsalves, are you going to want this going to kill my baby? So that's probably why she asked for a KCL. But I think this patient is not going to have a KCL before procedure.
I don't think so.
Yeah, but it's just for you to know, like, why Dr. Gonsalves asked for a KCL or something to stop heartbeat before the procedure. It's because this specific case so many years ago, it was not a pleasant comment. And I apologize to her, but still, it's not good that a patient tells you that you're the one. It's going to be an exciting case. I hope Fellow gets to participate in the case.
I think that's it, Dr. Roman.
Okay. Yeah, review the case of the acute fatty liver is very interesting, and we don't have that many. I think we had less than one case per year. Okay, so we are ready to go for lunch?
Think so.
Okay, see you.
Bye. Excuse me. Not very well, clearly.